Hi, good morning, everyone. Welcome to this session of ENT. This is ear day now, and we are done till now the larynx, the nose, and the pharynx. And I hope you could revise a couple of things. And हमने on कर दिया. I hope you could revise a couple of things out of these three topics. I know this is a very challenging time when you don't have got that much time available for the revision. And I can relate to, there are a lot of classes going on and there are only this much time left to revise and then, another day, another class. But just ask yourself one question that your seniors or your previous batch people also passed the same situation and they passed the exam. So it is a challenging time, no doubt about it. But you know what? We have to sail through this in a very systematic manner. In a more, I would say, stretch yourself. That's why I've been telling to you, in the usual 24-hour day, we don't get that much really, scope of revising if we are actually just following the previous routine we had. So when I say 5 hours, 6 hours sleep, I want to create a window for you guys to have more number of hours available for you so that you are able to revise. Even you get 2 hours extra apart from what you're getting now, believe me, in those 2 hours, at least you can revise major content what you did in the same day. So the baseline is that you must stretch your limits a little bit more, and then only the scope of revision would be, there. But just make sure that, don't lose heart. Don't lose heart, don't lose hope. That how will I do? Don't get, so much, I would say, overwhelmed by the classes and the material and all that. Because, everyone passes through the same thing, That's what the doctors are actually. We are supposed to work under pressures. We are supposed to work and deliver under pressures also. And this is one of the time when you are actually passing through that time. And I know we have not passed through this kind of time too often in our life. But believe me, if our seniors could do, we can also do. Just remember that. If they could do all these, revisions and all everything, then they can also do better. Okay? Now. So, allow me to go now the next topic of the ENT ear. And thank you for your wonderful messages on the email and the telegram. And I'm really humbled by those messages. I'm glad that you're learning. That's a very, very important thing for me, that in an online portal we are able to deliver so that you're able to learn the concepts of, ENT. So I'm really very much, I would say, sort of humbled and happy to really hear that you're you're actually trying to absorb the concepts of ENT. Wonderful. So ear, first of all. Now, first of all, in ear, we talk about embryology, beta. Embryology. Open up your notes, beta. Embryology, everybody. Open up the PDF and now open the ear part of it. Now, everybody open the ear part of it. Now let's start the ear for the day. Ear. Everybody reach over there. Ear is at the page number 82. And please use these pages, beta. I have asked them to keep one extra page everywhere in between so that you can put extra things over here. Don't really use these pages, beta. There is an extra page over here in the beginning of every section. Use this page, beta. Okay. Now, the embryology bit. Embryological development of pinna. Let us discuss the development of pinna and development of other part of the ear. What are the important points to remember? First of all, pinna, development of pinna, put an arrow. It is from first and second arch, beta. Development of pinna is from first and second arch, beta. Development of pinna is from first and second arch, beta. First and second arch. 2 arches, first arch, second arch. Development of pinna is from 2 arches, first arch and second arch, beta, arch. 1 and 2 arches, beta, arches. I hope you remember arches, beta. Arches, 1 and 2 arches means on the surface of the embryo of human, we have got certain elevation, beta. If you remember, can you see, do you remember that, beta? On the fetus head and neck, this is the fetus head, beta, is forming. And can you see these elevations here, these elevation like focus? Can you see arches means elevation? These are arches, and first and second arch, they are actually the site where the pinna forms, beta. Okay, pinna form. Now see, please on the screen, beta. Now please see, everybody, see over here. This is your tragus, beta. Now this is T mane tragus. Okay, tragus. Now tragus is from first arch, beta. Just look at your notes. Tragus is from first arch, number one, and the rest of pinna from second arch, beta. Tragus develop from first arch, rest of pinna from second arch, beta. So tragus is having separate development, but tragus is a part of pinna, beta. Tragus develop from first branchial arch, rest of pinna from second branchial arch. Okay. Now see over here. Can you see this line, beta? Can you see this red line? This line is the union of first arch and second arch. And this line is called incisura terminalis. Okay, let us write out, beta. Incisura terminalis, beta. INCISURA. Incisura terminalis is the junction of first arch and second arch. Incisura terminalis is the junction of first arch and second arch. Mind you, beta, tragus is a part of pinna, but tragus is a separate cartilage, but tragus is very well a part of pinna only. So tragus develop from first arch, rest of pinna from second arch, and incisura terminalis is the junction of first arch and second arch, and there is no cartilage in incisura terminalis, beta. In this area, there is no cartilage, beta. There is no cartilage in incisura terminalis, beta. There is no cartilage here, beta. Okay? There is no cartilage in incisura terminalis. So tragus is separate cartilage, rest of pinna is separate cartilage, but tragus is a part of pinna. Tragus develop from first arch, rest of pinna from second arch. Incisura terminalis is a junction of first arch and second arch, and this incisura has no cartilage, beta. Okay, fine. This much is clear. Now, what is hillocks of His, beta? Hillocks of His, beta. Now, please see when the human embryo is developing. Okay. Look at the last line, beta. Pinna development completes by 20th week, beta. Pinna development completes by 20th week of embryological life, beta. This is MCQ, beta. Pinna development completes by 20th week, beta. 20th MCQ, 20th. When the pregnancy is there, pinna develop by 20th week, beta. 20th week. Now let me show you the ultrasound of that time. When we do the ultrasound at 20th week. This is what it looks like, beta. Please see on the screen, beta. Can you see, beta, over here? This is the pinna, beta. Can you see a fetal ultrasound? And you can see over there that pinna is there, beta. This is the pinna over there. Okay, pinna over there. But you know what? It's not like that. The 20th week completed today, and suddenly, tuck, pinna comes out. Not like that, no? It's not 20th week of pregnancy completed today, and tuck, pinna comes out suddenly out of the fetus head. No, no, no. What will happen? Look at screen, beta. What will happen? First of all, 6 elevation will form. Okay, 6 elevation will form. These 6 elevation are called hillocks of His. Hillocks of His, HIS. They are 6 elevation, and then they fuse to form the final shape of the pinna. You understanding? First 6 elevation, hillocks means small hill. Hillocks of His means small hills are formed on the surface of the head of the embryo, and then they fuse to form the final shape of pinna, and final shape of pinna gets ready by 20th week of embryological life. Now everybody read, beta, hillocks of His, beta. Hillocks of His, just leave. During embryological development of pinna, 6 elevation form on the head and neck of the embryo, 6 area of embryo from first and second arches, which eventually fuse to form pinna, beta. Am I clear, beta? During embryological development of pinna, 6 elevation form on the head and neck area of embryo from first and second arches, which eventually fuse to form pinna, beta. These 6 elevation are called, everybody MCI question, hillocks of His, beta. These 6 elevation called hillocks of His. They are 6 in number, that's an MCI question, beta. These 6 elevation called hillocks of His, beta. HILLOCKS, hillocks of His. They are 6 in number. They are 6 in number, beta. And pinna development completes by 20th week is also the MCQ, beta. So 6 elevation is the MCQ, 20th week is the MCQ, beta. Now let us do the next topic. Congenital disorders of pinna. Disorders of pinna, beta. Now please see, can you tell me pinna develop from which 2 arches, beta? First arch and second arch, beta. First arch and second arch. I hope you know this diagram, beta. Pinna development from first arch and second arch, and this is a line of union of first arch and second arch. Imagine first arch and second arch do not unite with each other properly. Then there will be a sinus formation over here, and that sinus is called preauricular sinus. Preauricular sinus, beta. Everybody, first of all, look at the picture of preauricular sinus, beta. Can you see there is a hole in front of the pinna? Lot of time parents come to the clinic with the child and the child has got a hole in front of the pinna, beta. It's not just a hole, beta. It's not just a hole. It's a complete tract over here, beta. Only hole is visible. It's not just a hole. Sinus is a complete skin line tract, beta. Why it happened? Please understand. Because first and second arches do not unite with each other properly. When first and second arch do not unite with each other properly, there will be a sinus formation between the two, and that is called preauricular sinus. It looks like an opening in front of the pinna, beta. Can you see opening in front of the pinna? You know, as a doctor, you are not a student anymore. You're going to be a medical professional. You should know as a doctor that, okay, there is a hole in front of the pinna. What I will think the name of disease is preauricular sinus. Now let us read about it. Preauricular sinus, if the union of first and second arch is incomplete, it will lead to a congenital disorder called preauricular sinus. Have you read it, beta? If the union is incomplete, it will lead to preauricular sinus. Now, it may be symptomatic, it may be asymptomatic. If asymptomatic, it needs no treatment. If asymptomatic, it needs no treatment, beta. It needs no treatment. If asymptomatic, it needs no treatment. But look at this, beta. But if there is a recurrent infection, can you see? This is sinus opening over here. The sinus tract got infected. Can you see red infection over there? If the recurrent infection is there, then the treatment is surgical excision. Okay? If asymptomatic, no treatment required. But if there is a recurrent infection, then surgical resection of the tract should be done. Am I clear, beta? Surgical resection of the tract should be done, beta. Okay, very good. Let's go further, beta. We are doing developmental disorder of pinna, beta. Okay. Now, what is anoxia? Anoxia is absence of pinna. Microtia is small pinna, beta. Anoxia is absence of pinna. Microtia is small pinna, beta. Anoxia, microtia. Am I clear, beta? Anoxia, microtia. Anoxia, microtia. Now, next one. Next one. Bat ear. Normal pinna has two curvatures, beta. Let us understand bat ear now, beta. Everybody, look at the pinna, beta. Very interesting thing. Look at the pinna, beta. Look at the pinna, beta. Please see, a normal pinna has two curvature, beta. Outer curvature, inner curvature. The outer curvature is called helix, beta. Helix is the capital C, and anti-helix is small c, beta. Please see, every pinna has two C, beta, two curvature. Outer curvature, capital C is helix, and the small c is called anti-helix. Of course, this is helix and this is anti-helix, beta. Am I clear, beta? So very simple. If you look at your pinna in the mirror, you will see there are two curvatures: outer C, inner C, beta. Outer C is called helix, inner C is called anti-helix, beta. Anti-helix. Okay. Now, if anti-helix is absent, beta. अगर anti-helix नहीं है, if anti-helix is absent, it is called bat ear, beta. If anti-helix is absent, it is called bat ear, beta. Look at beta, bat ear. Can you see bat ear, beta? Bat ear. Your pinna has two curvatures, beta. Look at your pinna, beta. Look at the pinna in your mirror. Stand up and see in the mirror, beta. Get active in the learning, beta. Oh, go. You're a doctor, okay? Okay. Look at your pinna in the mirror. There is outer curvature, inner curvature, beta. Outer curvature is called helix. In capital C is helix, small c is anti-helix. But look at the bat ear, beta. Bat ear only has helix, beta. Helix. There is no anti-helix in this, beta. This is suiting her, but it will not suit our children. If it happens in humans, in our children, they will look like aliens, you know. Remember Amir Khan, they look like aliens like that, beta. Okay. Now look at our child, beta. Can you see, beta, over there? Can you see over there our child? Don't you think so? It's looking like alien, beta. Can you see? Only helix is there, beta. Only helix is there. They're like open like antennas like that, beta. Antennas like that. They're roaming around like antennas. So there is no inner curvature, beta. So I know as a doctor that normal pinna has two curvature: helix, outer curvature, anti-helix, inner curvature. If anti-helix is absent, like this patient, beta, just see on the screen, there is no anti-helix over here. Its disease is called bat ear, and this is only a cosmetic problem. Okay, this is, please understand as a doctor, write down side one. Use the sidebar for extra concept, beta. Right now, it's only a cosmetic problem. Hearing is not a problem, beta. Okay, it's only a cosmetic problem. Okay. Now, please see on the screen and look at your notes, beta, that Normal pinna has two curvatures called helix and antihelix. If antihelix is absent, it is called bat ear. Bat ear. It is called bat ear. It is called bat ear, beta. Bat ear. The cosmetic surgery of pinna is called otoplasty. Auto means ear, plasty means repair. It is done at 6 years of age, beta. MCQ. What is the ideal age of otoplasty? 6 years of age, beta. Why? Because by 6 years, pinna gains adult size, beta. Because by 6 years, it has fully grown by that time. Am I clear, beta? Fine. MCQ, beta. Fine. Bat ear, otoplasty, 6 years. Lot of question here, beta. So, OT means pinna, beta. OT, otoplasty. OT means pinna. Can you see, beta? Anotia. Can you see there is no pinna, beta? Anotia. There is no pinna. Anotia. A means absent. Nausea. Okay. But microtia means small pinna. So, OT means pinna, beta. Otoplasty, hai na? Anotia, microtia. I'm clear. Bat ear, I'm clear. Oh, bat ear is cosmetic problem, beta. Okay. And no problem. Now, next one. Development of other structures, beta. Tympanic membrane develop from all three layers: ectoderm, endoderm, mesoderm. Development of other structure: tympanic membrane develop from all three layers, beta. Ectoderm, endoderm, mesoderm, beta. Okay, one question. Now, development of ossicles. We're doing development of ear, beta. Development of ossicles. Malleus incus develop from first arch, beta. First arch. Stapes from second arch, beta. S for stapes, S for second, beta. S for stapes, S for second. Malleus incus develop from first arch, stapes from second arch. Anybody? Pinna develop from which arch, beta? First arch, second arch. Pinna from first arch, second arch. Ossicle from first arch, second arch, beta. Okay, bache? Pinna from first arch, second arch. Ossicles from first arch, second arch, beta. Am I clear, beta? Fine. Now, let us see the ossicle, beta. Let us label them, beta. This is M mane malleus, I mane incus, S mane stapes. Let us get familiar with the ossicles now. They are very small ossicle, beta. They are like rice grain size. Rice grain, you know rice grain? Rice grain size, beta. Rice grain, beta. Look at my hand, beta. In my this pinch, in this my pinch, 3 ossicle will come, beta. They're very small bone, beta. Rice grain, they're rice grain like. Somebody in Mumbai asked me, as a live class going on in Bombay, pre-COVID classes. He said, Dr. Rajiv, why you are giving always example of rice grain like that? Now, because I say corniculate, cuneiform cartilage, rice grain cartilages. Whatever impression you carry from your childhood, they are something which you start, giving as examples also. I told you because my father was having a small shop of ration. So I used to sit at the shop and you know what, whenever you are measuring anything, you're touching that and you know what, you develop your tactile memory from there. So, in fact, that's why I keep giving you. In fact, that was the time which gave me real motivation that I have to do something else in my life actually. Otherwise, if I would not have passed the exam of the medical entrance, I would have been doing the same thing. Also, it's not that that's a bad work. That's a lower. I'm not commenting on that. It's not that being a doctor is a really wonderful thing. I'm not saying that. It's just another profession. But yes, what you enjoy the most. What you enjoy the most. That you have to really see. And believe me, I never knew that medicine is going to be such an interesting thing, honestly. I never came to medicine by really information. I never had much of an idea. I took physics, chemistry, biology because my friends took physics, chemistry, biology. That's all. After my 10th class, I had to decide which way to go. I was okay in maths also. I was okay in science also. I was okay in everything also. I was okay in everything. No, not bad actually. Honestly, I was not bad. But I thought they are taking biology. I'll also take biology. At least we'll be going together to the school. You know what? So, at that time, I never knew that medicine would be such an interesting profession. But today I can tell you, you're going to be the future doctors. You should know that this profession takes time to settle. Yes, challenges are there. But it's a very satisfying profession. If you practice it well, if you practice it little ethically, I'm saying, I'm not asking you to become gods. But if you still maintain the ethics of the practice, you practice in a scientific structured manner, you do justice to the patients, it's a lot of rewarding experience. Financially, of course, yes. Otherwise also, financially, I told you, money will come. But money is going. There will be a delay of some years, but eventually money start flowing from here and there. But that is not a problem. But it's a very interesting profession to be in. I'm really grateful that I don't know why, but I took physics, chemistry, biology in 11th class, and I came this route because now I feel that this is what I actually am meant for actually. Okay, because when I was in the shop actually selling all those things, I was not really very excited about it. Every day was the same day kind of thing. Every day when you go from school over there to the shop, you are measuring the same thing. 1 kg will remain 1 kg only. No changes in that. Not that work is lower, but no work is lower, but no work, every work is having equal worth, I would say. Only thing is what you are meant for as a human being. And medicine is a very exciting profession to be in because a lot of human touch over here actually. Okay. So Malleus, Incus, Stapes, they are like rice grain like cartilages. Now cochlea. Cochlea is derived from otic capsule, which is neuroectoderm. Cochlea is neuroectoderm. Why? Cochlea is like retina. Cochlea is like retina. Dr. Anuradha must have told you, in online classes about ophthalmology, and retina is like neural structure. Similarly, cochlea is a neural structure, and it develops from otic capsule or neuroectoderm. Neuroectoderm. Okay. Cochlear development completes by 20th week. How many weeks? 20th. Cochlear development completes by 20th week. But 2020. Anybody? Pinna development completes by 20th week. Cochlea by 20th week. Ear by 20th week. Okay, fine. Am I clear? Fine. So cochlea, pinna develop by 20th week. Now next question. Which ear structure is of adult size at birth? Okay, adult size. Which ear structure is of adult size at birth? Okay, number one, middle ear. Number two, ossicles. Number three, cochlea. Middle ear. Number two, ossicles, cochlea. Means that they do not grow after birth. They are already of adult size at birth, and they are okay, they are absolutely good size at birth, and they do not need to grow after birth. Middle ear, ossicles, and cochlea are of adult size at birth. Now, clinical anatomy. Master tip is absent at birth. It develops at 2 years of age. MCQ. Master tip develop at 2 years of age. 2 years. Everybody touch behind your pinna. Everybody touch behind your pinna. This is the master tip area. Master tip area. Okay. So master tip is absent at birth. It develops at 2 years of age. 2 years of age. Okay. Fine. Now, let us start a discussion of middle ear ossicles. Middle ear ossicles. Let us start a discussion of middle ear ossicles. Middle ear ossicles. Malleus, incus, and stapes. Malleus is like a hammer. Malleus is like a hammer. The three ossicles. Bolo beta. Naam bolo. The three ossicles. Number one, malleus. Number two, incus. Number three, stapes. M-I-S. M-I-S. Malleus, incus, stapes. Now, just write down size wise. Malleus is bigger than incus. Incus bigger than stapes. If you look at a size, you can look at size. Malleus is bigger than incus. Incus bigger than stapes. Okay. Now, all of you look at this one. This picture. Label it. This is what, everybody label it, label it. This is your tympanic membrane. Tympanic membrane. Okay. This is your malleus, incus, stapes. Malleus, incus, stapes. Okay. Malleus, incus, stapes. This is which part of the ear? This is what? This is the middle ear. M-E mane middle ear. This is what the inner ear. I-E mane inner ear. Okay, middle ear. Middle ear contains ossicle, inner ear contains cochlea. Okay, so this is tympanic membrane. Behind that is malleus, then incus, then stapes, and then you have got inner ear. Inner ear contains what? Cochlea. Okay, just a basic orientation. And you can see malleus like a hammer. Hammer. Okay, malleus is attached to tympanic membrane. First ossicle behind tympanic membrane is malleus. Next is incus, then is stapes. Have you labeled this one? Okay. Now, everybody, let us see a small, video clip to understand it better. Please see on the screen. This is tympanic membrane. This is incus, malleus, incus, stapes, beta. So tympanic membrane is there, okay. Now you are actually looking tympanic membrane from all around. Tympanic membrane is the, the thing behind which is the ossicle. Now sound energy is entering your external auditory canal. It is going to touching your tympanic membrane. When tympanic membrane moves, the malleus move. When malleus move, the incus move. When incus move, the stapes move, beta. So this is a one system, beta. Tympanic membrane ossicle one system. So ossicles have got one assembly, beta. Assembly. Okay, like that. Malleus, incus, stapes have got one joint actually. They have got one jointed assembly like that. Let us do one thing. Let us separate them and let us see them one by one. Now this is malleus. Now this is incus. And finally this is the stapes, the third one. Stapes. So let us do one thing. Let us see the diagram of these ossicles. Let us know the various parts of the ossicles, beta. Okay, fine. Once again, beta, please see this concept is important, everyone. This concept is important, that when sound energy come, beta, when sound energy come, what happens is, please see, when sound energy comes in your external auditory canal, the tympanic membrane and ossicle move together. Sound energy is going, look at this, beta, tympanic membrane and ossicle, they move together. They move together and then they stimulate the inner ear, beta. Can you see stapes is moving like a piston? So move like a piston, okay, piston. So this is one system, beta. One tympanic membrane and ossicle, one system. But let us know the ossicle in detail now, beta. Okay. Now the next topic, beta. Everybody open up your notes, beta. Size-wise, we have written already. Malleus, incus, stapes. Stapes, smallest bone of the body. This is a PMT question also. Remember, pre-medical entrance exam questions. Smallest bone of the body, stapes, beta. Now, malleus, first of all. Malleus is like a hammer. Malleus is like a hammer, beta. Now look at me, beta. Malleus is like a hammer. Now look at me, English word, hammer. I must have seen a hammer. Now hammer has got a head. Hammer has got a handle. Imagine hathodi, beta, hathodi. Hammer is hathodi, hammer. Every hammer has one head and one handle, beta. Now look at screen, everyone. This is the head of the malleus, beta. Can you see head of the malleus? This is called the handle of the malleus. And the tip of the handle is called umbo. Bolo beta kya? Umbo. U-M-B-O. Umbo beta. Umbo. Okay. Now there is a process over here. And that process is called lateral process, beta. This side is lateral process, beta. And below the head, this area on this side is called neck of the malleus. Neck of the malleus. Am I clear, beta? This is neck of the malleus, beta. Let us revise everybody various parts of the malleus. Bolo beta, misal bolo. Number 1, head of malleus. Number 2, handle of malleus. Number 3, umbo. Umbo is tip of the handle. And number 4, lateral process of malleus. And number 5, neck of the malleus, beta. Neck of the malleus. Everybody clear, beta? Mainly 4 parts of malleus, beta. Now look at your notes, beta. Get familiar to all these words. Number one is the handle of malleus. Okay, handle of malleus, beta. Number 2, lateral process of malleus. Lateral means outward. Means towards tympanic membrane. Lateral means outward. Outward means towards tympanic membrane, beta. And then handle of malleus. And number 4, umbo. Umbo is tip of the handle, beta. So there are 4 parts of malleus. Bolo beta, what are 4 parts? Number 1, head of malleus. Number 2, lateral process of malleus. Number 3, handle of malleus. And the tip of handle is called umbo. Okay. Now number 2, incus, beta. Incus. Incus is a little smaller than that. Now incus has a body. Look at screen, beta. Look at the diagram, beta. Incus has a body, okay, number 1. Number 2, short process, over here, beta. Can you see short process, beta? Short process. Number 3, long process. And the end of long process is called lenticular process, okay. Once again, speak with me. Incus 4 parts, beta. Body, short process, long process, lenticular process. Once again, speak with me. The 4 parts of incus are body, short process, long process, and lenticular process. Lenticular process, lens-like process, beta. Okay. The end of the long process is called the lenticular process. Once again, beta, what are 4 parts of the malleus, beta? The 4 parts of malleus are head of malleus, number 2, lateral process of malleus, number 3, handle of malleus, and number 4, umbo, beta. Okay. Same incus, 4 part. Rather than head, there is body. Rather than lateral process, there is short process. Rather than handle, there is long process. And the end of long process is like lenticular process, beta. Okay, fine. Chalo. Now let's do the stapes, beta. Now stapes is like a inverted cup on a plate. Okay, inverted cup on a plate. It has got 2 parts. Can you see what are 2 parts? The Stapes is like a cup on a plate. Look at my hand, beta. As if you kept a cup, inverted cup on the plate, beta. The cup, inverted cup part is called head of stapes or superstructure of stapes, beta. Head of stapes or superstructure of stapes. And the plate is called foot plate of stapes, beta. And the plate is called foot plate of stapes, beta. Am I clear, beta? Head or foot plate, beta. Am I clear, beta? So it is inverted cup on the plate, beta. Now, head, underline or, just cut it the word or, beta. Head is equal to superstructure of stapes and foot plate of stapes, beta. Now, foot plate of stapes, beta. Look at screen, everyone. Look at screen. Look at this picture, beta. Look at this picture, everybody. Please see. Look at this picture in your notes only. This is the stapes, beta. Stapes attached at, what is it, beta? Cochlea, beta. है ना बेटा? The foot plate of stapes. Can you see clearly, beta? Can you see? The foot plate of stapes, this one, beta. This one. The foot plate is this one. It's attached to some part of cochlea. है ना? Foot plate is attached to some part of cochlea, and it is attached to which part of cochlea? Now look at your note, beta. Foot plate of stapes, it is attached at oval window of cochlea. Foot plate of stapes is attached at oval window of cochlea. Oval window of cochlea. Am I clear, beta? Oval window of cochlea. Okay, oval window, okay, of cochlea, okay. Now, stapes acts like a what? Stapes acts like a piston. Stapes acts like a piston. Piston. Look at my hand, beta. Look at my hand, beta. Stapes is like a piston. Beta. Stapes is the end of middle ear, beta. Stapes is the end of middle ear and beginning of inner ear, beta. Stapes is at the gate of the inner ear, beta. Stapes is the end of the middle ear and beginning of the inner ear, beta. So, stapes is attached, foot plate of stapes attached at oval window of cochlea, and it rocks the inner ear like a piston. It is actually the gate of the inner ear. So it is knocking at the gate of inner ear, beta. How does it knock? To make you hear, how does it knock? It knocks like a piston, beta. Stapes acts like a piston, okay, fine. Now look at screen, everyone. What do you mean by piston, beta? Now please see on the screen. Can you see the stapes, beta? Can you see the stapes, everybody? Can you see the tympanic membrane, malleus, incus, stapes, beta? Can you see, beta, over here? Once again, if you see, now please see, this is your exonotory canal, tympanic membrane, malleus, incus, stapes, and this is what, beta? Inner ear, beta, cochlea. This is cochlea has two window, beta. Oval window, round window. Oval window, round window. There's nothing at round window. But oval window has got stapes footplate attachment. Footplate of stapes attached at oval window of cochlea. Now look at the movement of the stapes, beta. Look at the movement of stapes. Can you see stapes, beta? Everybody look at the stapes, beta, over here. Focus on this area. How the stapes is moving, beta? It's like a piston. It's knocking at the gate of the cochlea, beta. Okay, can you see it moving like a piston? When it moves like a piston, what happens is the cochlea gets stimulated, beta. The cochlea gets stimulated when cochlear membranes move, beta. Due to stapes movement, cochlear membrane moves, the cochlea produces electrical energy, beta. Electrical energy goes to your brain, beta, and you hear it. Once again, please see, beta. Stapes acts like a piston. Stapes attached to oval window of cochlea. When the piston-like movement moves the fluids of the cochlea, the membranes of cochlea move like that. When membrane of cochlea move like that, the cochlea gets stimulated and it produces electrical energy which goes to the brain via which nerve? Eighth nerve, beta. What is eighth nerve? What is eighth nerve? What is the name of eighth nerve? Vestibulocochlear nerve. This is cochlea only. Vestibulocochlear nerve. This is cochlea only, beta. Okay? So stapes acts like a piston. Now, if this piston is fixed, come back to the note, beta. If stapes is fixed, it will lead to a disease called otosclerosis. Very important topic, otosclerosis. Okay, beta, otosclerosis. Oto means ear, sclerosis means fixation, hard. If stapes is fixed, it will lead to a disease called otosclerosis. Okay. Can you see this picture, beta? Everybody? Can you tell me what is this ossicle, beta? M. What is M, beta? Malleus. What is it, beta? I. Incus. What is it, beta? Tympanic membrane. What is it, beta? E is C means external auditory canal. Okay. C means cochlea. And this is the problem, beta. Can you see around the stapes there is extra bone formation, beta? Can you see around the stapes there is extra bone formation, and that has caused the fixation of the stapes, and this is a disease called otosclerosis, beta. At least I should know what is otosclerosis. First of all, that stapes is a piston. If the stapes gets fixed, jammed, and that disease called otosclerosis, beta. Now you tell me, beta, if stapes is jammed now, can you hear properly? No, because stapes has to act like a piston, free moving piston. But stapes is jammed here. Something has surrounded the stapes. How can the cochlea stimulate properly now? Okay. So if stapes is fixed, it will lead to a disease called otosclerosis. Beta. Very good. Chalo. Now middle ear mechanics, beta. Next topic, middle ear mechanics. Now I know by now tympanic membrane and ossicle work as one unit. Oh yes, I've seen. Tympanic membrane is attached to malleus, malleus to incus, incus stapes. It's one unit, beta. They work together. Okay? They work together. They work as one unit. This assembly conducts sound energy to inner ear, beta. I know. Stapes gives sound energy to inner ear, beta. So middle ear has got one function of conducting the sound energy to the inner ear, beta. Am I clear, beta? Fine. Now look at this, beta. Malleus, incus, stapes, beta. And foot plate of stapes is attached at the cochlea, beta. Fine. Okay, but can you see one thing? As you are going forward, the size of the structure is decreasing, beta. Malleus is biggest ossicle, incus is smaller than that, stapes is smallest ossicle, beta. As you are going forward, look at me, beta. As you are going forward, look at me, beta. As you are going forward, the structure size is reducing. Malleus, incus, stapes. Stapes is very small bone, beta. I hope you remember physics, beta. Physics says that whenever any energy, this is which energy, beta? Sound energy. Whenever any energy focuses from a big area to a small area, it will get amplified, beta. I hope you remember the basic common sense, beta. Whenever any energy, what is this energy, beta? Sound energy. Okay, it is hitting the tympanic membrane. That goes to malleus, malleus to incus, incus to stapes, stapes to the cochlea finally, beta. Okay, fine. So whenever any energy focuses from a big area to a smaller area, it will get amplified, beta. Amplified, beta. Okay. Now if you got in your phone, Instagram is open, Facebook is open, and YouTube is open, and your Telegram question are also open, beta. Every window is open on your tablet or iPad. Everything is open. And you are sometimes doing Telegram questions, sometimes doing your notes, sometimes you're doing Instagram, sometimes you're doing Facebook, sometimes you're watching a YouTube video also. Then your energy is dissipated in 5 different corners. Then you cannot have the amplification of your energy, beta. Humans are also, what is human, beta? Human is combination of 2 things. Energy plus a limited time span. Energy plus limited time. You have got energy and you have got a time span of 3 months. Energy plus limited time span, beta. Okay. Now, time span you cannot do anything. Time span is fixed for all. Everybody has got the same time for 3 months only. Today is 4th, Anna. So we have got limited time for 3 months only. But energy is in your hands, beta. You want to invest the whole energy into one thing, study, there will be amplification of that. If you want to do 10 different things at one point of time, nothing is of much concrete impression for the brain, beta, unfortunately. If you hear a song, beta. If you hear one song, hear a song only, beta. For some time, for 3-4 minutes, forget about everything and just hear that song. Unfortunately, we were never taught all this in the school. We should have been taught. There should be a curriculum of living. There should be a curriculum of studying also. Why we are subjecting so many students to unnecessary, problems? I don't know why. I wish we could start it in India that, okay, there's a curriculum of living actually. There's a curriculum of studying also that, first of all, you are a wonderful human being. Whatever you are really great. Yes, you need to trim a couple of things out of you and you need to change your focus point in the area at the juncture when it is supposed to. At this juncture, you're supposed to focus all your energy. If you're focusing all your energy only on the books, there'll be amplification, beta. What is amplification? Brain will get a richer, deeper impression of that part of the notes or that particular question. Same is happening over here, beta. As you are moving forward, you are focusing same energy from a bigger area to a smaller area. It gets amplified. So that's why they say middle ear causes amplification of sound energy also, beta. Okay. Now look at the next point. Middle ear also amplifies sound energy. This amplification is called middle ear transformer ratio, beta. This amplification is called middle ear transformer ratio. And in your case, if you amplify your energy, this will be a life transformer ratio, beta. Life transformer ratio, beta. Why not we? See, energy is energy, beta. Human is also nothing. What we are, we eat food, we create energy. We eat food, we burn that, create ATPs, and we are nothing but a source of energy. We want to utilize this energy for X thing or Y thing or Z thing. That decision is a conscious decision. You want to keep sulking all through the day. What if I fail again? What if I fail this time? I have less time. I have so many classes. How will I revise? What will happen? Will I recall? Will I not recall? You can keep on doing all those things, or you can just say, this factor is common for everyone. Let me try to put my best foot forward. Let us do our best. Let us forget the rest. Let us leave the rest to God, beta. Let me do my best. In the 3 hours left after the classes, how much can I study? I may not be fully. I can't revise fully. Whatever I can study, I should be doing that with a lot of focus, energy, enthusiasm, very well knowing that I'm not the perfect, I'm not the best, beta, but I'm trying to do my level best, beta. And that amplification will create a life transforming event for you. At least it happened in my case for sure. And I'm sure you can also do. If I can do, you can also do, beta. If a person like me who has got 100 ways of getting distracted, it's a very difficult thing for me to focus on one thing. I just cannot. It's not my inherent property, beta. Some people have got inherent. My wife has inherent property that she can focus on one novel and finish it one night. I cannot do that. I will never read. No, I don't read books actually. I don't understand the books honestly. Most of these so-called books and all beyond my comprehension. Even if she gives me some book, it will take me months to complete that. I can't focus with it. That's not my inherent property. But what I do is, I keep working on myself. I keep working every day. I live a day. Okay, kal jo hua so hua, koi problem nahi. Today I'll do things differently, beta. Let me see how much productivity I can generate out of the day, beta. Okay, and this amplification is called middle ear transformer ratio, and middle ear transformer ratio is 18:1. Can you imagine? 18:1 means you invested 1 rupee, it became 18 rupees, beta. 18 rupees. This is what can happen with you also if your mobile phone and tablets are free of clutters, beta. Free of clutters right now. And if your mind is absolutely focused in studying as much as you can, very well knowing that I'm not the best, I cannot predict my result, I cannot control my result, I cannot control the exam, but I can control my productivity in the day, beta. Then look at the amplification. 18 times, beta. 18 times, beta. The main function of middle ear is this whole thing is called impedance matching mechanism, beta. Impedance matching mechanism. Just remember this word. It's a very, very core concept of ENT. When you come for NEET PG, I'll definitely talk in detail about this, beta. Okay. Main function of middle ear is, this is a NEET PG question. This whole thing collectively called impedance matching mechanism, beta. Impedance matching mechanism. Now, let us go further, beta. Now we're going to discuss every part one by one. Pinna to the inner ear. Let us start from pinna. Everybody touch your pinna. Your pinna, beta. Not your neighbor's pinna, beta. I hope you are, if you are living together, three people, 3-4 people still living together, studying together, cooking together, being together. Let us hold hands of each other, beta. If one of you, if you are 3 people staying or 2 people staying or 5 people staying together, if one of you feels low, it's your responsibility to pick that guy or girl out of that negativity and make sure that he or she also studies better. Why should we do that? Are we here to become, gods? No, not at all. Not at all, beta. We are trying to improve the grace element in our life, actually. The grace element is, have you heard the Newton story, beta? Have you heard, everybody looks at the Newton story. The Newton was lying under a tree and an apple fell down and he thought that this is gravity, which is pulling the apple down to the ground. But everybody forgot one thing. Everybody forgot one thing. At the place where an apple was falling down from the tree to the ground, at the same place, a tree was growing against the gravity upward. I repeat, at the place where the apple was falling due to gravity towards ground, at the same place that apple tree was growing against gravity towards the sky. If the apple falling towards gravity is your own effort, beta, energy, effort, then the tree growing against gravity towards sky is the grace element in your life, beta. Grace is unpredictable, undefinable element in your life, beta. You cannot define that. You cannot predict that. What will happen on the exam day? If you're stuck at 148, some 3-4 wild guesses might be correct on the day, and you stand on 152 and you pass the exam. What is going to decide whether grace blesses you or not? This cannot be defined. But you can enhance the grace element in your life. How? By being generous to other people, by being kind to other people, by helping them out, not pulling anyone down. If someone is down, hold the hand and take him along. Take him along, you know what? If somebody doesn't feel like studying today, sit with him, make him revise something which you did just now. Talk to him that why you're not studying, let us sit together and study. All these things are going to increase the grace element in your life. All these things are not from any book, not borrowed from some concept like here and there. These are the things which I've lived through, which I felt many times in my life actually. Something was not deserving something, I got it. I got it. I don't know why I got it. I don't know why I got that. I don't know why I got that. As a child, I always wanted to go to Paris. In my village in Amritsar, I was looking at the newspaper, and I was seeing the Eiffel Tower. I always wanted to go to Paris as a 10th class student, 9th class student. It was my dream to go to Paris actually. But can you imagine from a village in Amritsar going to Paris? It's not easy to really see the path. How will happen in future? I became a doctor. Then I took an ENT. I came to Delhi. I am not a malignant person. I don't mean ill to anyone. And I was in Coimbatore for a conference of otology, of 4 days, Coimbatore conference. And 4th day, they had a viva and a theory paper, multiple choice question paper for a fellowship, travel fellowship, which I never knew it's for Paris actually. I thought it's they sponsor some doctors, 2 doctors every year for learning for 3 weeks, ear surgery. I appeared in that MCQ test, I passed it. Next day, the 8 people were shortlisted. Only 2 had to be given the fellowships. Out of 8, 2 were girls, 6 were boys. They always choose 1 girl and 1 boy. Out of 6 boys, only 1 had to be chosen. All 5 were really much above me, honestly speaking. Much above me from all sort of possibilities. We appeared in the interview. It went well. In the evening, it was announced that my name, Rajiv Dhawan, is selected for travel fellowship to Paris. I was shocked. I was not knowing that it's Paris. Just a travel fellowship. I said, it must be in India only. To Paris with one of the most famous ear surgeon of France. His name is Andre Sultan. They gave me tickets. They gave me place to stay for 3 weeks. They gave me money for the lunch and dinner. Breakfast is with the professor. Always. Is it not grace, beta? Is it not? I never deserved that. All the people were much better than I was. How come it happened to me? And I reached Paris. Every night I used to catch metro from my apartment. I used to go to Trocadero. Trocadero is the name of the metro just below the Eiffel Tower. Every night I come out of Trocadero metro and look at the Eiffel Tower and look at the Eiffel Tower, and I used to sometimes get tears in my eyes, like that. That what is this? What? I never deserved it. I just thought about it as a child. How come it happened? I don't know. Is it from a book? No, it's my experience when I say that. When you are genuinely generous to other people, the grace blesses you. The nature is watching you. We all are collection of energy. Let us hold hands. May everyone pass. May everyone pass, beta. None of you should really leave a single opportunity to help your fellow beings, because you're not just helping him or her, you're helping yourself also. You're increasing the grace element in your life. Sometimes you get stuck at 147, 146, and you never know. 5-6 question wildly guessed by you got correct, and you got 154, 153, and you passed the exam. And suddenly the whole thing changes in your life. Everybody looks at you as like wonderful doctor. So why not do that? Not for other people, for us. For us, it's good to become generous for not for other people. Not it's again this selfish reason over there to increase the grace element in your life. So today, let us promise. If we see one person low, we'll make sure that he gets better. If a roommate feels low, we'll not leave his hand. If a roommate is getting annoyed with something happening in the room, we'll make sure that we don't do that to disturb him. If you deserve to pass, if you belong to one parents, then that person, that girl or that boy also belong to one family. Both families invested so much of money into the career of the children. Everyone deserves to pass. So may everyone pass. So let us hold hands and work on this together. May God bless everyone. May God bless your hard work. I cannot predict your result. I can tell you the ways to enhance the possibility of your passing. And this is one of them. Now pinna. Pinna is made of yellow elastic cartilage. Covered by skin. Of course, touch your pinna, not other person pinna. Your pinna, beta. This is pinna. It's nothing but cartilage and skin. Skin is closely attached to cartilage on the lateral surface. Beta. Skin is closely attached to cartilage on the lateral surface means front side. Beta. This is lateral. Beta. Everybody mark it. Beta. No confusion. Oh, this is lateral surface. Beta. Lateral surface. Okay, this is lateral surface. Beta. Skin is loosed on a medial surface. Medial means the back surface. Beta. Back side. Back side towards skull. Okay, fine. So I can touch, beta. All of you touch your skin on the cartilage. It's actually closely attached on the lateral surface. If you all of you touch this area, beta. If you touch the skin on this area, it's actually closely attached to the cartilage, but on the back side over here, beta. On the back side, it's little loose, beta. Little loose, beta. Okay. Now, nerve supply of pinna. Very important nerve is greater auricular nerve. Greater auricular nerve, beta. Main nerve supply of pinna is greater auricular nerve, beta. It is the main nerve supply of pinna. It also supplies lobule of pinna. And write down one more question. New question for general surgery. This nerve can be damaged in parotid surgery. This nerve can be damaged in parotid surgery, beta. Parotid surgery, beta. Here. The parotid is here now. Look at everybody. Ear, below the ear is which gland? Parotid gland. Beta. Okay. Okay. Fine. So how do they, what is lobule of pinna, beta? What is lobule of pinna? Please see on the screen. This is the lobule of pinna, beta. Everybody mark it, beta. Lobule. Lobule is the soft part of pinna, but this is the lobule of pinna, the soft part of pinna. How will they make a question? Patient suffering from pleomorphic adenoma of the parotid gland underwent superficial parotidectomy. After the parotid surgery, the patient is complaining of loss of sensation in the lobule of pinna. In the lobule of pinna, the loss of sensation is there. Which nerve got damaged? The answer is greater auricular nerve. Beta. Greater auricular nerve. Beta. Greater auricular nerve. Beta. Am I clear, beta? Fine. Is it clear to everyone? Okay, fine. Next one, beta. Next, let's do, beta. Disorder of pinna, beta. Number one, pinna hematoma. Pinna hematoma, it is due to trauma, beta. Pinna hematoma is very common, and a lot of people fight, a lot of people get injured with each other. They fight and then they hit each other and then they get hematoma, beta. Can you see, beta, injury, beta? Somebody punches with love on your pinna and you get a beautiful hematoma like that, beta. Beautiful hematoma. So pinna hematoma, look at your notes, beta. It is due to trauma. Trauma. Can you see trauma, beta? Trauma. Something happened like that due to trauma. It is subperichondrial hemorrhage. I hope you know, the cartilage is covered by perichondrium, so it is below that, beta, subperichondrial hemorrhage. Treatment is aspiration or drainage plus pressure bandage. MCQ, beta. You should do the aspiration or pressure bandage, beta. Yesterday class. Septal hematoma, look at, beta, trauma. Look at me, beta, septal hematoma. Remember my friend's story who had an accidental, injury by the gate of the mall. Septal hematoma, what was the treatment of my friend actually? aspiration. Otherwise, it will convert to septal perforation. Similarly, if you don't do this, otherwise it will lead to necrosis of cartilage, which leads to post-traumatic pinna deformity. And that pinna deformity is called as boxer ear or cauliflower ear, because it is more common in boxers. If pinna cartilage is necrosed, pinna shape is lost. Am I clear, beta? Okay. Otherwise, it will lead to necrosis of cartilage. It will lead to, which leads to post-traumatic pinna deformity called as boxer ear or cauliflower ear. Beta. Boxer ear or cauliflower ear. Okay. Can you see boxer ear or cauliflower ear? Beta? This is the boxer ear. Beta. Put an arrow like that. This is the boxer ear. Beta. Very simple, beta. If you don't drain or aspirate the pinna hematoma, it will damage your cartilage, and the cartilage damage will lead to shape of the pinna being deformed, and that deformity of pinna after trauma is called boxer ear or cauliflower ear. Beta. Is it clear to all? Beta? Clinical topic, beautiful topics. Beta. Now, keloid pinna. Beta. Just a visual question. Keloids, I hope you know keloids from surgery, keloid hypertrophic scar and all that. Pinna can be site of keloid. Pinna. And most commonly it's seen on hallux. Beta. Beautiful laddu, beta. Can you see laddu, beta? Beautiful laddu, and it is on which part? Hallux, beta. Why? People do the piercings over here. Nowadays, people want to put not one earring, beta. They want to put 10 earrings, beta. And people have a tendency to make keloid. So they get a punching of the hole over here, and then at that hole, the keloid form. Not everybody will make a keloid, but some people have got a tendency to make keloids, beta. Next one, Darwin tubercle. It is an anatomical variation. It's not a disease, beta. Darwin, you know Charles Darwin, remember evolution, beta? It's a conical elevation on hallux, beta. Hallux. This is the Darwin tubercle, beta. Everybody mark it, beta. This is the conical elevation of hallux. Darwin tubercle is not a disease. It's a conical elevation of hallux. It's only anatomical variation, beta. It's only anatomical variation, beta. Am I clear, beta? Okay, fine. So Darwin tubercle is clear. Now, let us start the next beautiful topic. External auditory canal, also called as external auditory meatus. We will call it EAC. For us, EAC is external auditory canal. Beta. From now onwards, it can be canal or meatus, but we'll call it canal. Beta. Canal. EAC means external auditory canal. Now, what is external auditory canal? Beta? Everybody look at screen. Beta. External auditory canal means when you go inside the from pinna, when you go inside, this is external auditory canal. Can you see, beta? Can you see, bache? This is external auditory canal. Can you see outer part has got hair follicles, hair follicle, hair follicle. And when you go deeper into external auditory canal, at the end you see which membrane? Tympanic membrane, beta. Okay, once again, beta. This is the external auditory canal, beta. This is the external auditory canal, beta. Can you see external auditory canal? From pinna you are entering, beta, over here with endoscope. Outer part has got hair follicles, beautiful hair follicles. The moment you go deeper into it, inside there is no hair follicle, clean, ear is clean. And what is the end of the external auditory canal? Which membrane? Tympanic membrane is attached over there, beta. Okay? Now let us discuss this. I hope you're enjoying ear, beta. It's like understandable. None of you would try to memorize anything today. No memorizing pressure on you. Only understanding responsibility. There are notes in front of you. There are diagrams in front of you. Everything is there. Only live the moments with me, beta. Understand the anatomy with me. Live the clinical things with me as you're standing with me in the hospital with the clinic like that, beta. Okay? So that we are confident doctors of the future. Okay? EAC is 24 millimeter in length, beta. 24 millimeter in length. Outer 8 millimeter is cartilaginous. Inner 16 is bony, beta. Outer 8 is cartilaginous, inner 16 is bony. Okay? The bony EAC is made by tympanic part of temporal bone. Bony EAC is made by tympanic part of temporal bone. Yes. Now everybody label it. This is which bone, beta? Temporal bone, beta. This is temporal bone, beta. Okay? Now this is your external auditory canal, beta. Everybody put an arrow. This I'm talking about this one, beta. This is what the M, beta. M is what? Mastoid part of temporal bone. Mastoid part of temporal bone. Okay, beta. Axonometry canal. This is tympanic part of temporal bone. Right on tympanic part. You should get used to the temporal bone, beta. Ear is designed within temporal bone, beta. This is a temporal bone, okay? Now, all of you, where is the temporal bone? On the side of the skull, okay? This is which part of temporal bone? This is the tympanic part of temporal bone, beta. And all of you palpate behind your pinna, beta. All of you palpate behind your pinna. What is this, beta? This is mastoid part of temporal bone. All of you palpate behind your pinna. This is mastoid part of temporal bone, beta. Guys, we think mastoid is behind the ear. Don't you think so? We have a concept, oh, mastoid to kaan ke piche hota hai. Mastoid is behind the ear. Why? Mastoid is not behind the ear, beta. Mastoid is a part of the ear. Mastoid is a part of the ear, my dear friends. It's very well a part of the ear. Mastoid is a part of the ear, beta. Okay? Why we get this impression? You know, why we think pinna is the ear, beta. Please understand. Somewhere we start thinking pinna is very important design of the ear, beta. Pinna, look at my pinna, beta. Pinna is nothing, beta. Is a cosmetic structure only, beta. Pinna has got, if you chop your pinna, there'll be no hearing problem. There's no hearing problem. If your inner rest part are working normally, if you chop your pinna, there won't be any hearing loss, beta. Pinna is more cosmetic thing. Don't think this is the ear, beta. Ear starts and ends over here. Ear is three-dimensional thing like this. Pinna is only attached to your skull so that we look presentable at least. If there's no pinna, we would have looked like boiled eggs, beta. You know, aliens, remember? Jadoo yaad hai? Koi mil gaya. All aliens, E.T., you know, aliens. If there is no pinna, we'll look like boiled eggs, beta, boiled eggs, like aliens, you know, remember? You know, why there are eyebrows, beta? Why the eyebrow also cosmetic, beta? It's not that eyebrows are catching the Wi-Fi signals. Do you think eyebrow catch the Wi-Fi signals? No. Do you think that eyebrows, when it is raining, they come out and cover your eye? No, nothing like that. It's only cosmetic again, beta. Why? Nature wants species member should find each other attractive. Species member should want each other. Species members should like each other, should find each other attractive, beta. You know why? What is the basic instinct of the brain, beta? Brain wants to make babies, beta. Brain wants to make baby. Brain is the inherent structure designed by nature to create more humans, so that nature keep experimenting out of the genetic pool, beta. That is what. All these things are to create attraction amongst each other. That's all. Hair, eyebrows, pinna, they're like just to make you look presentable at least. Otherwise, kaan nahi honge. Can you imagine? How will I look like? Can you imagine? Almost remove my hair, remove my eyebrows. I look like a boiled egg. So, pinna is not the end and the beginning of ear, beta. Ear is three-dimensional thing like this, and mastoid is a part of the ear, beta. Okay, everybody? Now, one more concept, bache. Everybody, look at screen. Where is the temporal bone? This is your temporal bone, beta. Okay, can you see temporal bone, beta? And I'm sure you know this is the tympanic part of temporal bone. This is mastoid part of temporal bone, beta. One part of temporal bone is inside the skull, beta. Can you see, beta, the actual temporal bone, beta? Oh, anatomy. This is the tympanic part of temporal bone, mastoid part of temporal bone. Ear, mastoid is a part of the ear, beta. Am I clear? Now see on the screen, beta. Temporal bone, okay. Now my concern is temporal bone has got a very big part in the skull also. Temporal bone is not only the outside, beta. This also is temporal bone, beta. Everybody look at screen, beta. This is also temporal bone, beta. This is called the petrous part of temporal bone. This is called the petrous part. Temporal bone is going in the skull like this also. Outside tympanic part, mastoid part. What is the inside part? Is the petrous part, beta. Petrous part. Now look at me, everyone. Look at me, everyone. When I say external ear, middle ear, inner ear. When I say external ear, look at me. We are going in the skull, beta. External ear. Then you say middle ear. Then you say inner ear. Where you are going? You are going deeper and deeper into temporal bone. External ear, middle ear, inner ear. Over here, beta. Ear is located within temporal bone, beta. Now please look at screen, beta. Look at screen, everyone. When I say axonometry canal, it's within over here, beta. Tympanic part. Then comes the middle ear. Malleus, incus, stapes are here only, beta. Within the temporal bone. When I say inner ear, beta, cochlea, it's here only, beta. In the temporal bone. In the temporal bone. External ear, middle ear, inner ear, beta. External ear, middle ear, inner ear are lying deeper and deeper into temporal bone. What lies over here, beta? What lies over here is brain, beta. You know brain? Brain over here. From the brain, two nerves come, beta. Seventh nerve, beta. What is seventh nerve? What is seventh nerve, beta? Seventh nerve is what? Facial nerve. Facial nerve, beta. And that passes through the this is seventh nerve, passes through the ear and comes out, beta. Comes out. Let me draw with the other color, beta. Let me draw with other color. This is a facial nerve. It passes through the ear and comes out, beta. Okay, bache? Fine. And then comes the eighth nerve, beta. Eighth nerve enter the ear and supply the inner ear, beta. You know what is eighth nerve, beta? Because you know, eighth nerve is seventh nerve is facial nerve. It passes through the ear and comes out of the ear to supply the face, beta, over here. But eighth nerve, the vestibulocochlear nerve, is going to supply the cochlea, beta, inner ear. Eighth nerve is for inner ear. Eighth nerve is for inner ear. Vestibulocochlear. Vestibulocochlear means the inner ear, beta. So eighth nerve. So look at the design, beta. External ear, middle ear, inner ear, brain. External ear, middle ear, inner ear. What is next to the brain? Same on this side also, beta. External ear, middle ear, inner ear, brain, beta. So both sides, temporal bone, temporal bone. External ear, middle ear, inner ear, brain. And same external ear, middle ear, inner ear, brain, beta, brain. What connects inner ear to the brain? Which nerve? Eighth nerve. What connects inner ear to the brain? Eighth nerve, beta. What is eighth nerve? Vestibulocochlear nerve, beta. And facial nerve passes through the ear and it comes out to go to the face, beta. Face. I hope this is clear to you. Now, let us go further, beta. EAC is lined by skin. Everybody? EAC is lined by skin. Outer part skin has hair follicles and ceruminous or wax gland, beta. The wax glands are also called cerumen. Cerumen means wax, beta. Ceruminous gland or wax gland, which are modified apocrine gland, beta. From the histology perspective, wax gland are modified apocrine glands. Modified apocrine glands, beta. Okay, fine. Now, some people produce more wax. Can you see? Some people produce more wax, which leads to occlusion of EAC by wax collection, beta. Can you see, beta? Some people produce more wax. Can you see? Kaan pura band ho gaya. The EAC occlusion due to wax collection. This leads to CHL. Yes, what is CHL, beta? Conductive hearing loss. How much? 30 decibel, beta. MCQ, 30 decibel. You cannot hear any sound up to 30 decibel. This is 30 decibel. You cannot hear any sound up to 30 decibel, beta. Treatment is syringing. Treatment is syringing, beta. Treatment is syringing, mera bache. Syringing matlab you put water in the ear to flush the wax out, bache. So can you see, beta, over here? Can you see syringing, beta? Treatment is syringing, beta. Can you see? Put water carefully. If you don't put water carefully, it will come to your face, beta. It will splash on your face. Oh, it went on her face, beta. Did you see that? This is what syringing. You're putting water in the ear to push the wax out, beta. Okay? Now please see some questions, beta. The direction of water is posterior superior. The direction of water is posterior superior. Very famous question. What is the direction of water in syringing is posterior superior. Direction of water is posterior superior, beta. This is important question. Which direction you put the water? Posterior, superior? No, posterior superior. It will hit over there. It will touch the wax and wax will flow out, beta. Posterior superior, beta. Direction of water is posterior superior, beta. Use water at room temperature. Avoid cold water. MCQ, beta. MCI question. Avoid cold water because it can lead to vertigo. It can lead to vertigo, beta. Avoid cold water because it can lead to vertigo. If you stimulate your inner ear with cold water, you can feel imbalance. You know, imbalance means vertigo. So don't use cold water because it can lead to vertigo, beta. Vertigo. Now on the side, write down. One more question. Syringing can lead to syncope episode. Patient बेहोश हो जाता है. Patient can suddenly turn unconscious during syringing. Okay, syncope or vasovagal episode. Vasovagal. Remember vasovagal episode, beta? Vasovagal episode. Remember in your school time when you have not eaten anything and you are standing in the prayer in the assembly, morning assembly, and suddenly you feel, there is black, you see black, and then you fall on the ground only, beta. Because you suddenly, you just fall on the ground. Have you felt that ever? When you're not eaten the breakfast, you're not had the breakfast, you're standing in the morning assembly queue, over there, and then suddenly everything turns, little, hazy, fuzzy, and your eyes are getting, blurring, and then blackout, and then you fall on the ground, beta. Even syringing can do the same thing, beta. Syringing can lead to syncope or vasovagal episode, MCQ, beta, because of stimulation of auricular branch of vagus. Auricle mane pinna, auricular branch of vagus, beta. Okay, so this is an important question for MCI paper, NEET PG paper. Syringing can lead to syncopal or vasovagal episode due to stimulation of which nerve? Auricular branch of vagus, beta. I hope you know vagus is parasympathetic nerve. Vagus leads to bradycardia. है ना? Vagus stimulation will lead to bradycardia, na? Vagus carries parasympathetic innervation, beta. Okay, so why people develop vasovagal or syncopal episode? मतलब they turn unconscious suddenly due to stimulation of which nerve? Auricular branch of vagus nerve, beta. Am I clear, beta? This is MCQ, beta. Important question, already came in MCI, beta. Okay, chalo. Next one. Direction of ESC. Look at me, beta. Look at me, beta. Direction is tortuous. It's tortuous. In adults, direction is tortuous. Tortuous, beta. It is inward, downward, and forward. Look at me, beta. Look at me. Look at me. Of course, skull mein inward, inward, little downward, and then forward. Inward, downward, forward. Inward, downward, and forward. Therefore, look at the screen, beta. Therefore, look at the screen, beta. When you are examining the ear, can you see the doctor is pulling the pinna? Doctor pulls the pinna in reverse direction. If canal is directed inward, downward, forward, the examiner pulls the pinna upward, outward, and backwards. Write down. During examination of ear, pinna is pulled upward, outward, backwards. Upward, outward, backwards. Upward, outward, backwards. Okay, bache? That was inward, downward, forward. This is reverse of that. Upward, outward, backward. Upward, outward, backward. This is which test? But this is what being done. Otoscopy. Otoscopy. Otoscopy has got what? A light bulb and magnification. Light bulb and magnification, beta. Light bulb and magnification. Okay, bache? Fine, beta. Light bulb and magnification also, beta. Okay, bache? Fine. This is light source. Have you heard the word ophthalmoscope? Same otoscope. Light source and magnification, beta. Okay, fine. Chalo. Let us do the next one. Fissure of Santorini. These are some natural defect. There are some natural defect. These are, beta. These are some natural defects in EAC in cartilaginous part, beta. Okay. What are fissure of Santorini? Every person has got some defect in the cartilaginous part of the EAC, and that cartilaginous defect in the EAC is called fissure of Santorini, beta. Fissure of Santorini. Okay, bache? Fine. Am I clear, beta? Okay. What is the significance, beta? EAC infection can reach the parotid gland. How EAC infection reaches parotid gland, beta? Logical question. I've seen couple of patients. Look at me, beta. This is extranauditory canal, which is this gland, beta. Which is this gland? Parotid gland. Is there an EAC infection that can go to parotid gland through which anatomical area? Fissure of Santorini. Think like a doctor, not just anatomist, beta. Think like a doctor. Fissure of Santorini is a natural defect in the cartilaginous part of the EAC. Agreed. But what is the importance of this is, through the fissure of Santorini, EAC infection can reach the parotid gland, and that is the clinical significance of this, beta. So clinical anatomy. Okay. Now, next question, beta. Live insect in the EAC, beta. Live insect in the EAC, beta. Live insect in the EAC, beta. Live insect in the EAC. Oh, तुम्हारे कान में कॉकरोच चला गया. cockroach goes in the ear, beta. Live inside the EAC, beta. Look at screen, everyone. Can you see there is a cockroach in the ear, beta? Can you see there is a cockroach in the ear? And cockroach is dancing like that. Oh, Nancy. Would you try to remove it live, beta? You tell me. Would you try to remove this cockroach live, or will you kill it and then remove it, beta? Don't try to remove it live, beta. Why? Because it might be holding your tympanic membrane also, and when you put the cockroach out, the cockroach brings your tympanic membrane also out, beta. You don't want that? No, na. First kill it. Kill it, beta. Killing doesn't mean that. Killing doesn't mean that you put hit spray, black hit spray, kala hit spray in the ear. Cockroach, hai na? No. Red hit spray. No, bhai. No, not that. No hit spray, beta. Put oil in the EAC to kill it and then remove it, beta. Put oil in the EAC to kill it and then remove it, beta. Okay? This is MCQ. Practical question, beta. Okay? Put oil in the EAC to kill it and then remove it, beta. Which somebody asked me, which oil, sir? I said any oil except kerosene oil. Any oil. Particularly mustard oil is very commonly available, but no, not kerosene oil, beta. Okay? Fine. Now comes the sensory nerve supply of EAC. Everybody come to the next page now. There are three nerves, beta. Three nerves. Number one, right on. Always put the numbers, beta. 1, 2, and 3. Okay. Now, first of all, auriculotemporal nerve. Look at the auricle, mane pinna, temporal bone. Auriculotemporal nerve. It supplies anterior wall and roof of EAC. Anterior wall and roof of EAC. Beta. Okay, bache. Then come the auricular branch of vagus nerve. Vagus nerve. Put an arrow. This is same thing. It is put an arrow. It is also called Arnold's or Edelman's nerve, beta. It is also called Arnold's or Edelman's nerve, beta. Arnold's nerve or Edelman's nerve, beta. Okay. Now, stimulation of this nerve leads to cough. Very, very important question. Cough, beta. Have you seen this nerve is so important, beta? So many questions on this nerve, beta. Auricular branch of vagus, it can lead to vasovagal episode or syncopial episode. Or when you are cleaning the ear, patient suddenly started coughing. Why? Which nerve got stimulated? Auricular branch of vagus. Vagus leads to cough, beta also. This is clinical anatomy. Very possible question in NEET PG or the MCA paper also, beta. Stimulation of this nerve leads to cough, beta. They will make a story. A doctor was cleaning the ear of the patient with cotton. Suddenly, patient started coughing. Which nerve has got stimulated? Auricular branch of vagus, also called as Arnold's nerve or Edelman's nerve. Bolo beta, what is the other name of auricular branch of vagus? Arnold's nerve or Edelman's nerve, beta. Okay, beta. The third one, sensory division of facial nerve, also called as nerve of Würzburg, beta. Nerve of Würzburg. Okay, facial nerve. Okay, also nerve of Würzburg. It supplies the posterior superior part of the EAC, beta. Only small part. Everybody draw. Only this much part of the EAC, beta. Put an arrow. It only supplies very small part of the EAC. Posterior superior part of the EAC. Only very small island of the EAC. Posterior superior part of the EAC, beta. Posterior superior part of the EAC. Okay, bache. Let us revise this, beta. Let us revise this, beta. There are three nerves which supply the EAC. Everybody speak with me. Number one is auriculotemporal nerve. It supplies the anterior wall and roof of EAC. Then comes the auricular branch of vagus, also called as Arnold's nerve or Edelman nerve. It supplies the posterior wall and floor of the EAC. Stimulation of this nerve leads to cough, beta. Okay? This is very important, beta. Okay. The third one is sensory division of facial nerve, also called as nerve of Würzburg. It supplies posterior superior part of EAC, beta. May I remind you, none of you should try to remember anything at this point. Understand it, get used to the notes, what is written where, make a concept, beta. Oh, think like a doctor. You are doing syringing, patient turned unconscious. Which nerve got stimulated? Auricular branch of vagus. You were cleaning the ear, patient started coughing. Which nerve got stimulated? Auricular branch of vagus. What is the other name of auricular branch of vagus? Arnold's nerve or Edelman's nerve. This is how I want you to spend the day. Okay? Now, disease of EAC, beta. Disease of EAC. Number one, diffuse otitis externa. It includes the infection of complete skin of the EAC and or pinna, beta. Look at the name, diffuse mane pura otitis externa means that the outside ear got infected, beta. Outside part of the external ear. So it is infection of either pinna or EAC or both, beta. Okay? EAC and or pinna. Okay. Treatment is topical antibiotic and ear drop. Can you see, beta? The whole pinna and the ESC skin is infected. No question, for only for your clinical knowledge. If you see something like this, call it otitis externa, beta. Okay. It's also called, swimmer ear, tropical ear, okay, Singapore ear or telephone ear, beta. Okay. Now, why it is called swimmer ear? Beta, swimmer ear is the main thing, beta. If you don't want to remember anything, please remember swimmer ear, beta. Don't forget swimmer ear, beta. Why? Moisture goes in your ear and that moisture facilitates the bacterial growth over there, and that's why it's swimmer ear, beta. Okay, fine? Fine, beta? Fine. Chal. Just mark over Singapore ear, beta. Put an arrow. Singapore ear is just deleted over here, beta. There's a controversy on this topic, beta. Delete Singapore ear, beta. I'll tell you, there's a controversy going on this Singapore ear. Let's not make the name of a country actually. Okay, swimmer ear is the main thing, beta. Swimmer ear, beta. Okay, fine. Why tropical ear, beta? Tropical climate is humidity, beta. Humidity supports bacterial growth, beta. No question on this. Only remember swimmer ear is other name of diffuse otitis externa. That you should remember. Now next one, beta. Localized otitis externa. Localized otitis externa, called furunculosis or boil. Furunculosis or boil, beta. Furunculosis or boil. Localized otitis externa called furunculosis or boil, beta. Furunculosis or boil, beta. Look at see, beta. Can you see, beta? There is boil, beta. Okay. Can you see? Boil. Okay. Now, can you tell me, it is staphylococcal infection of the hair follicle, beta. Hair follicle. Can you tell me hair follicle are in the outer part or inner part, beta? Remember, hair follicle. I told you, hair are in the outer part. Inner part has got no hair, beta. Every time you see the hair over here, but if you go a little deeper in the external canal, you don't see any hair. So furunculosis is actually follicle of the hair got infected. So of course, furunculosis will be seen in the outer part of the ESC only, beta. Now read your notes, beta. Read your notes. This is furunculosis, beta. Can you see furuncle over there? Can you see furuncle? Boil. In English, boil. Hindi mein foda. Fincy, foda is boil. Foda, fincy, boil. It is staphylococcal infection of hair follicle. It is seen in the outer part of the ESC because I know from anatomy, hair are only seen in the outer part of the ESC, beta. Okay. Now, one thing write down, beta. Treatment is IG packing, beta. What is IG? Write down. Ecthamamol. Glycerine packing. Ecthamamol glycerine packing, beta. Ecthamamol glycerine packing. The special color pack, special solution is available. You'd soak some cotton in this medicine and put in the ear, beta. What is the name of the pack, beta? Ecthamamol glycerine packing. This medicine is a black color medicine, only used for furunculosis, beta. One more thing, beta. In this case, write down one thing. On side, write down. Examination in this case, write down tragal tenderness, also called tragal sign positive. Tragal tenderness or tragal sign positive, beta. If you press the tragus in this case, tenderness is what? What is tenderness? Pain on pressing. Tragal tenderness or tragal sign is positive, beta. Tragal tenderness or tragal sign is positive. Of course, beta. Look at screen, beta. I think it's not difficult to imagine. If you press this area, patient will have pain. You press the tragus, look at me. Press the tragus in this area, patient will have a lot of pain, beta. Tragal tenderness or tragal sign is positive. Am I clear, beta? Fine. Okay. Don't forget, ecthamamol glycerin is MCQ. It is staphylococcal infection of hair follicle is MCQ. Tragal tenderness is the question, beta. Tragal tenderness or tragal sign positive. Okay, very good, very good. I hope you're enjoying the process of learning. My concern is that your day should not be a very boring day. Your day should be an exciting day. You should look forward to learning these things as a doctor. That's why my main concern is. Now, malignant otitis externa. Malignant. It's infection, beta. Infection. It is infection of underlying bone of the ESC, beta. Please see, beta. It's not skin infection. It's infection of underlying bone of the ESC. ESC has got a bone. Okay, it is infection of underlying bone of the ESC, beta. It is infection of underlying bone of the ESC, beta. Okay, bache, fine. Look at screen, beta. This is your tympanic part of temporal bone lined by skin, beta. This is your external aortic canal, na? Pinna is over here, beta. Pinna is attached over here, beta. This is the real bony part of exonotory canal, beta. Okay. Now this red thing is the skin. Now, if the infection is only limited, in the skin, beta, here, it is simple otitis externa, yellow pus, beta. If the infection is only in the skin, it's called simple otitis externa. But if the infection goes into the deeper bone, beta, over here, this is called malignant otitis externa. Why? It's not a simple bone. Look at me, beta. It is making the skull base, beta. Can you see? This makes the base of skull. Hai. Okay, that's why it's a very risky infection, beta. Okay, so look at your note, beta. It's infection of underlying bone of the EAC. It's also called skull base osteomyelitis. Okay, okay. It says that's why it's a life-threatening infection, therefore called malignant. Okay, it's not a cancer. On the right hand side, on the side, write down. It's not a cancer, beta. Don't confuse it. It's a cancer, beta. It's not a cancer. Malignant word has come from English word. Malignant means life-threatening. Malignant. It's too malignant. Okay, it's a life-threatening infection, therefore called malignant otitis externa. It is seen in old diabetic patient, beta. It is in old diabetic patient, beta. Old diabetic patient. Typical question will be diabetic patient, beta. It is caused by Pseudomonas. Very risky infection in diabetic patient. Pseudomonas. Think like a doctor. You are running your general practice. 60-year-old diabetic patient comes to a clinic and he says what? Clinical picture. Severe earache, beta. This is a learning for a doctor. A diabetic 60-year-old person to your general practice coming and he says, beta, I have got pain in the ear. Diabetic patient pain in the ear, think carefully. It may be beginning of malignant otitis externa. Severe earache. Number 2, blood-stained ear discharge. Doctor, there is some pus coming from a ear and it has got blood staining in that, beta. Blood-stained ear discharge. Because bone infection will lead to granulation formation. You know, granulation is red in color, which bleeds also. Blood-stained ear discharge. Plus minus facial nerve palsy, beta. Very common, beta. Facial is the most commonly involved nerve, beta. Very commonly, these diabetic patient will have within few days facial palsy also. Why? This disease is eating the bone of the ear. Which bone? Temporal bone. And you know, facial nerve passes through the ear. And when facial nerve is passing through the temporal bone of the ear, then this infection eats the bone. It may eat the facial nerve also, beta. So facial nerve is the most commonly involved nerve. I told you it is skull base osteomyelitis. It's a skull base infection. And I know from your anatomy knowledge that many foramina of the cranial nerves are on the skull base. That's why 9th, 10th, 11th, 12th nerve palsy. Plus minus means maybe there, may not be there. Plus minus 9th, 10th, 11th, 12th nerve palsy due to skull base infection. You think logically, skull base osteomyelitis. Where are the foramina? Skull base, beta. Okay, examination. Granulation in the EAC. Granulation are red in color, beta. Granulation are red in color, like this kind of thing on the bone. And that leads to blood-stained ear discharge. Why there is blood-stained ear discharge? I hope you know from orthopedic knowledge, whenever there is osteomyelitis or bony infection, on that bone there is a red granulation tissue formation of pathology. And that granulation tissue will bleed and that's why blood-stained ear discharge, beta. Okay, treatment is, drug of choice is 3rd generation cephalosporin. Pseudomonas, beta. Try to recall pharmacology knowledge of anti-pseudomonal antibiotic. The drug of choice is 3rd generation cephalosporin, beta. 3rd generation cephalosporin. 3rd generation cephalosporin, beta. Okay, fine, beta. 3rd generation cephalosporins, beta. Let us revise this topic, but this is important topic. How this question will come, everybody. Let us discuss this topic, beta. Old diabetic with ear question is 100% malignant otitis externa answer, beta. I repeat, old diabetic ear question, it is 100% malignant otitis externa question. What is malignant otitis? Is it a cancer? It's not a cancer. It's a risky infection of the underlying bone of the EAC. It's a skull base osteomyelitis And that's why it's very risky to the life of the patient. Typical profile will be old diabetic patient, beta. Okay, 60 to 70 years, beta. This is a typical question, 60 to 70 years, beta. It is caused by Pseudomonas. That's why drug of choice is third generation cephalosporin, beta. Okay, Pseudomonas, anti-pseudomonal antibiotic, third generation cephalosporin. Facial nerve is very commonly involved. Diabetic old patient with earache, think about it. Okay, that's how we solve the question, beta. It's not that you know every nitty and gritty of medicine surgery, beta. You know the main thing, you know the answer. Oh wow, that's a difference between ulcerative colitis, Crohn's disease is important, beta. Mecal diverticulum has to come in the paper, beta. Colorectal carcinoma has to come in the exam, beta. You can't run away from that. Volvulus has to be there. It has to be there, beta. You can't run away from these things. Intersusception will be there, beta. Will be there. You can't really run away from that. So it's not that topics are really too hidden here and there. Yes, there are rare topics, but can we just bother about the rare topics and forget about the mainly asked 90% of the content of the exam, beta? No. I believe in smart preparation. I'm not saying forget about the rare ones, but yes, lay more stress on learning, revising the commoner things, do their question, get confident about the questions, and may God bless us, we see on that day those questions and we pass the exam, beta. Okay? Otomycosis. It is fungal infection of the ESC, beta. Now, it is also called the Singapore ear, beta. A lot of books have created controversy in this, but I'm changing it, beta, because this is a very controversial topic. Singapore ear is the word used for, again, moisture problem, beta. Fungal infection, moisture. They call it's not bacterial infection, it's a fungal infection. Okay, fine, Singapore ear. It is a fungal infection of ESC. The most common fungus, again, not Candida, beta. Most common fungus is Aspergillus niger. Niger, ear. Yesterday, most common fungus for sinusitis was Aspergillus fumigatus. Yesterday was fumigatus. Today is ear, niger, N-I-G-E-R, ear, beta. अपने आप याद आता है, niger. Second common is Candida. It is more commonly seen in rainy season, beta. You know, coastal weather, Singapore weather, very humid weather. So that's why it supports it. Patient gets itching in the ear, beta. Itching in the ear. And when you look in the ear, there's a fungus colony in the ear, beta. Can you see fungus colony, beta? Can you see fungus spores over there? Little black, little white, and little wet also. Can you see, beta? There's a moisture here. Little black, little white, little wet. It is looking like a piece of wet newspaper. So examination shows which type of appearance? Wet newspaper appearance. Write down. Examination shows, very important question, wet newspaper appearance. The fungus colony gives which type of appearance? Wet newspaper appearance. Oh, wet newspaper appearance. Examination shows wet newspaper appearance. Wet newspaper appearance. Examination shows wet newspaper appearance. Okay. Treatment. Oral toilet. Oral toilet means clean. Toilet means clean, beta. Simple word, clean. Clean the ear, beta. Clean the ear, beta. Toilet means to clean the ear by suction. You have got a suction machine in the OPD. You suck the whole thing out, or by cotton you mop it and bring it out, beta. Suction or dry mopping with a cotton tip probe, beta. Dry mopping, beta. Will you do syringing in this, beta? You tell me. Apply your common sense. Can you do syringing by putting water in the ear to remove it? Can you do that? You should do that. No. Syringing, water, moisture will further aggravate fungus, beta. So, dry mopping or suction. Don't do syringing to bring it out, beta. Okay? Okay, then you give antifungal ear drop like clotrimazole, nystatin, beta. You know better than me. The antifungal ear drop are many available. Mostly we use Candid ear drop, beta. Candid. You know, Candid is very common. What is Candid containing? Clotrimazole or nystatin, beta. What are two questions to be remembered, beta? Wet newspaper appearance is the MCQ. Fungus gives which appearance? Wet newspaper appearance. And second is, most common fungus is Aspergillus niger, beta. Otomycosis, two question is wet newspaper appearance and Aspergillus niger, bache. Okay. Now, exostosis. Osteosis, beta. Just write, E is missing, beta. Write down, beta. Exosteosis, beta. Exosteosis. It's also called surfer's ear, beta. MCQ. Swimmer ear is different. Swimming is different. Surfing is different. It is hyperplasia of bony EAC. Beta. It is also called surfer ear. It is hyperplasia of the bony EAC. Look at screen, everyone. This is exosteosis or surfer's ear. Beta. Can you see surfer ear? I hope you know surfing is a sea sport. Sea sport, beta. The sea salty water enters the ear of these sports people and that irritates the bone of the exonotory canal and that bone gets hyperplastic. Can you see, beta? Can you see extra bone formation here, beta? Can you see extra bone formation here, here, here? Extra bone ban jana, exosteosis. The name says that exosteosis means extra bone formation. This is a tympanic membrane and exonotrical bone is hyperplastic. Beta. Extra bone, extra bone, extra bone here. It is the hyperplasia of the bony ESC. Beta. Am I clear, beta? Surfer's ear, beta. I will not confuse surfer ear with swimmer ear, beta. Surfer ear is exosteosis because of the sea salty water entering your ear irritates the bone of the ear and bone gets hyperplastic. Extra bone formation, exosteosis. Okay, bache? Swimmer ear was diffuse otitis externa. Am I clear? Fine. Chalo, beta. It is more common in water sport person, so it is called surfer's ear, beta. So it is called surfer's ear, beta. So it is called surfer's ear, beta. It is more common in water sports person, therefore it is called surfer's ear, beta. Am I clear, bache? Fine. Okay. So can you tell me what is bat ear? Everybody, what is bat ear? Bat ear is absence of antihelix. Boxer ear, cauliflower ear is after trauma, deformity of pinna. Swimmer ear was diffuse otitis externa. Singapore ear was otomycosis. Surfer ear was exosteosis. Don't you think so? All these should go to the 20th copy in those ENT pages, 5 lines about that. Don't you think so? Thyroplasty of larynx, 1, 2, 3, 4. Medialization, lateralization, shortening, loosening, lengthening, tightening. Indication of that should go into that 20th copy, beta. Such kind of things you will find in all subjects, beta. Very, very concrete, very sharp, very to the point things, very syndromes, triads, something like very unique. Transfer that to, but don't write it with every revision on there, beta. First you read the whole chapter, finish it off, make a sense of that chapter. Then when you are revising the second time, at that time you transfer it. Don't in the first revision, don't do this, beta. Otherwise you write too much of data on that side, beta. In the second revision, keep that copy. And this copy will be reading when? From 28th May to 3rd of the June, beta. At that time. We'll be revising all the images of radiology, pathology images, surgery images, derma images, all telegram question shots taken, beta. Whatever question is like you like, take a shot, take a screenshot and save in that folder. All these things will be doing in a very smart way in the last 1 week before exam. Okay, let's take a quick break. Quick break. It's a 15-minute break. 15-minute break. And after that, we start the tympanic membrane. Let's get excited to know about our beautiful eardrum, beta. You know eardrum? So come back to me after 15 minutes to learn about your eardrum, beta. Eardrum. Okay, chalo. Hello guys, welcome back. Chal. Now, let us start the next topic, tympanic membrane. Beta. Tympanic membrane. Tympanic membrane is right at the end of the external canal. I think you saw that video also, and you saw that, okay, when the external auditory canal ends, the tympanic membrane starts. This external auditory canal outer part has got hair follicle, external auditory canal is lined by skin, wax gland are also outside. Then you go deeper, inside there are no hair follicle in the external auditory canal, and then this is the tympanic membrane. Can you see, beta? That's the tympanic membrane. Now let's discuss. Can you see the color and everything, shape and everything? Let us discuss everything in that now. It is also called marring, first of all. Whenever you see the word maringoplasty, marringotomy, you are thinking about tympanic membrane. Beta. Tympanic membrane is also called marring. So maringoplasty, marringotomy is tympanic membrane. Beta. It is what in color? Write down. It is pearly grey in color. It's not white in color. It's pearly grey in color. Beta. You can see it's like a pearly grey. Beta. Hyderabad pearls. Hyderabad pearls? Like a pearly grey in color. Beta. Oval in shape. Beta. It's not circular. It's oval. Oval in shape. The diameter is 9 to 10 millimeter. 9 to 10 millimeter. Diameter is 9 to 10 millimeter. Millimeter. The surface area is 90 square millimeter. 90 square millimeter, beta. This is exactly of the size of the Disprin tablet. Have you seen Disprin tablet, beta? Disprin tablet is the size of tympanic membrane. Don't think it is so big, beta. When we look at it, very big. No, it's not that big. It is very small membrane. It's size of the Disprin tablet, beta. Okay. The area is 90 square millimeter, but effective area is 45. Why the effective area is lesser? Because peripheral part of tympanic membrane is more mobile than central part. When I say mobile, what do you mean by it, beta? Mobile. I hope you remember, sound energy creates movement of tympanic membrane, beta. That movement of tympanic membrane moves the malleus, beta, incus, then stapes. So actually what happens is, look at the screen, beta. This is the central part of tympanic membrane. This is the peripheral part of tympanic membrane. Actually, peripheral part shows more movement than the central part. Therefore, the effective area is 45 square millimeter. This part doesn't show too much of movement, but the peripheral part creates more movement. So peripheral part is more mobile than central part. Therefore, the effective area is 45 square millimeter. TM is lying at an angle of 55 degree with horizontal. 55 degree with horizontal, beta. TM is lying at an angle of 55 degree with horizontal, beta. All of you draw this, beta. This is external auditory canal. This is tympanic membrane, beta. The angle is 55 degree. Okay. With the external auditory canal, tympanic membrane is lying at an angle of 55 degree with horizontal, beta. Okay, 55 degree with horizontal. Look at me, beta. This is your external auditory canal. This is your tympanic membrane, beta. Tympanic membrane. Okay. Now please look at me. This is your external auditory canal and this is your tympanic membrane. It is not standing at 90. This is tympanic membrane, beta. This hand is external auditory canal. Okay. Now please see, it's not standing at 90, beta. It is bent like this. So this is tympanic membrane. The tympanic membrane makes an angle of 55 degree with the horizontal. When I say horizontal, horizontal means the external auditory canal, beta. Okay. So it has an angle of 55 degree with the horizontal, beta. Okay. Next point. TM shows movement on Siegeleization. Siegeleization, beta. New word, beta. Bolo beta, kya naam hai? TM shows movement on Siegeleization. Everybody, what is the word? Siegeleization. Bolo. Siegeleization. What is Siegeleization? Siegeleization means, first of all, look at screen, beta. Everybody look at Siegeleization, beta. Siegeleization means this one, beta. Can you see? Siegeleization. Siegeleization means putting air pressure on tympanic membrane with the help of a speculum, which is called Siegel speculum, beta. This is what we call Siegel speculum, beta. Siegeleization means, look at screen, beta. Look at screen. Siegeleization means putting air pressure on tympanic membrane with the help of an instrument called Siegel speculum. Siegel speculum has got a lens and a bulb. Look at me, beta. You put this lens in the ear of the patient and you see like this. Then you press this bulb and this is Siegeleization, beta. Putting air pressure on tympanic membrane is technically called Siegeleization, beta. am I clear beta? Fine. Is technically called Siegeleization. Okay. Chalo. So read beta. Siegeleization means putting air pressure on tympanic membrane. It is done with the help of Siegel's speculum. Beta. Everybody mark it. This is Siegel's speculum. Beta. Siegel's speculum. Get used to the image also. This is what speculum? Siegel's speculum for the ear. Beta. The technique is called Siegeleization. The instrument is called Siegel's speculum. Beta. Now, TM has 4 landmarks. Beta. What are the 4 landmarks? Handle of Malleus, lateral process of Malleus, umbo, and cone of light. Why there are landmarks? Beta. Look at screen, everyone. Why there are landmarks? Beta. Guys, can you see what lies behind the tympanic membrane? Everybody, let us label this diagram. Beta. Everybody, label the diagram with me. Just see over here. What is this? Beta? This is external auditory canal. Okay. What is it? Beta? Tympanic membrane. And then the first ossicle is M mane malleus. Beta. Can you see malleus is actually attached to the tympanic membrane on the back side. Beta. This is middle ear, na? Okay. Malleus is attached to tympanic membrane from back side. Because it is so much attached to tympanic membrane from the back side, it is slightly visible through it. Beta. But is whole of malleus visible? No. This is the end of the tympanic membrane. Beta. This is tympanic membrane from here to here. What is this? Beta? This is the head of malleus. Beta. So head of malleus is above the level of tympanic membrane, so head cannot be seen. Beta. What is this? Beta? This is what? Beta? This is what? Beta? Handle of malleus. Beta. Handle. What is this process? Beta? Lateral process. What is the tip of handle called? Umbo. So you can see 3 things. Beta. One is handle of malleus, then this process called lateral process of malleus, then umbo is the tip of the handle. Beta. Okay. Now in the real tympanic membrane, if you see, this is your tympanic membrane. Beta. Okay. Now where is the malleus? Beta? First of all, let us focus here. Beta. Let me draw it for you. This is your malleus, handle of malleus, lateral process of malleus. Okay. Now please see, this is a handle of malleus. This is number 2, lateral process of malleus. This is number 3, umbo, and number 4, cone of light. Beta. Okay. Now all of you read your notes. Beta. Tympanic membrane shows 4 landmarks. Number 1, handle of malleus. Number 2, lateral process of malleus. Number 3, umbo. Umbo is tip of handle. And number 4, cone of light. I will remove the marking and you see now yourself. Beta. Can you see handle of malleus here? Beta? This one. This is number 1. Beta. This is number 1. This is number 2. Beta. Number 2 is lateral process of malleus. This is number 3. Beta. Number 3 is umbo. And can you see shining light? Number 4, cone of light. Beta. Everybody, are you clear about the 4 landmarks of tympanic membrane? Number 1, handle of malleus. Number 2, which process? Lateral process of malleus. Number 3, umbo. And number 4, cone of light. Beta. Am I clear? Beta? Fine. Now everybody go back to the notes now. See. Handle of malleus, number 1. Okay, number 1. Number 2, lateral process of malleus. Number 3, umbo. And number 4, cone of light. Beta. Okay, fine. Can you see in this diagram also? Beta, he has drawn, lateral handle of malleus, number 1. Number 2, put a number 1, number 2, lateral process of malleus. Number 3, umbo. And number 4, cone of light. Beta. Number 4, cone of light. Handle of malleus, can you please be sure? Handle of malleus is clear? Yes. Lateral process of malleus is clear? Yes. Number 3, umbo is clear? Yes. And cone of light is clear. Beta. Is it clear to all? Okay. Now, something about cone of light. How this cone of light forms? Beta? Cone of light is formed by reflection of light from handle of malleus. Cone of light is formed by reflection of light from handle of malleus. Which light? Beta? Light of otoscope. Light of otoscope. Beta. Otoscope has a light bulb. Na? Look at me at this tympanic membrane. The otoscope light strikes the tympanic membrane and it gets reflected downward. Beta. And that is called the cone of light. Cone of light is produced by reflection of light from handle of malleus. Which light? Otoscope light. Beta. Cone of light position. Beta. Right ear 5 o'clock, left ear 7 o'clock. Position is very much clear. Right 5, right on right 5, left 7. L bane L 7. 7 is the L 7. L ko ulta karo 7. L ko ulta karo 7. Beta. Make the L reverse, it is 7. Beta. Right ear 5 o'clock, left ear 7 o'clock. Right ear 5 o'clock, left ear 7 o'clock position. Beta. Okay, bache? Okay, right 5, left 7. Okay, right 5, left 7. Beta. Okay, now this one is right. Write down right 5, left 7. Beta. Okay, now next one. Beta. Can you see beta? Right is 5. Beta. Can you see this one is at 5 o'clock? This one is 7 o'clock. Beta. Right 5, left 7. Beta. Okay, now next one. Now tympanic membrane has two parts. Beta. Pars tensa, pars flaccida. Beta. Number one, pars tensa. Highlight pars tensa. PT. Pars tensa is PT. Beta. Pars tensa. PT. It has three layers: outer skin, inner mucosa, middle fibrous layer. Okay, it has three layers: outer skin, inner mucosa, middle fibrous layer. Beta. Pars tensa makes the majority of tympanic membrane. Majority of tympanic membrane. Pars tensa makes majority of tympanic membrane. Beta. Pars tensa makes majority of tympanic membrane. Write down. It is the lower part of tympanic membrane. It is a stronger part of tympanic membrane. Add two word, beta. It is lower part of tympanic membrane. It is stronger part of tympanic membrane, beta. Lower part, stronger part, beta. Lower part and stronger part of tympanic membrane. Okay, fine. Pars tensa, outer skin, inner mucosa, middle fibrous layer, very strong part of tympanic membrane. No. Okay. Now look at me, beta. Look at me, everyone. Can you tell me tympanic membrane develop from which layer, beta? Ectoderm, endoderm, or mesoderm? Tympanic membrane develop from all the three layers, beta. Ectoderm, endoderm, mesoderm. If you go to embryology notes, beta, if you go to first part of the ear, development of the ear, tympanic membrane develop from all three layers: ectoderm, endoderm, mesoderm. Beta. Look at screen, beta. Ectoderm makes the skin, endoderm makes the mucosa, and mesoderm makes the middle fibrous layer. So all three layers makes one layer. Ectoderm makes the skin, endoderm makes the mucosa, and the mesoderm makes the middle fibrous layer. This is a 90% tympanic membrane is pars tensa only. The lower part, the bigger part is the pars tensa, and it is a stronger part. It is a very tense part, but a stronger part. But there is small part, pars flaccida, PF. Pars flaccida. It is also called Sharpnell's membrane, is MCQ, beta. It's also called Sharpnell membrane. It is flaccida, beta. It is, write down, it is the upper part, weaker part, smaller part. Upper part, weaker part, smaller part. It is the upper part of tympanic membrane. It is the weaker part of tympanic membrane. It is smaller part of tympanic membrane. Tensa was bigger part of tympanic membrane, stronger part of tympanic membrane, lower part of tympanic membrane. Okay, but this one is upper part of tympanic membrane, weaker part of tympanic membrane, and smaller part of tympanic membrane. Okay, why it is weaker, beta? In this middle fibrous layer is almost absent, beta. Unfortunately, this area is weaker, flaccida, because in this you do not have any middle fibrous layer, beta. Okay, it forms a small upper part of tympanic membrane, beta. Okay, small upper part of tympanic membrane. You say, Rajiv, where is all this, beta? In the real tympanic membrane, if we see, where is the tensa and flaccida, beta? Now please see, this is the picture, beta. Now see, let us see this tympanic membrane and let us understand from the doctor which is tensa, which is flaccida, beta. Guys, can you see, beta? This is what, beta? This is the lateral process of malleus. Lateral process of malleus. Let us do one thing. Let us draw a line at this level, beta. Let us draw a line at this level of the lateral process of malleus. Draw a line, beta. Above this line is pars flaccida. Below this line is pars tensa, beta. Okay, beta. Can you see, beta, a small triangular area? This area, it's a weaker area, beta. Pars flaccida. Okay. Please see. Once again, revise. Pars tensa. PET means pars tensa. It forms the lower part of tympanic membrane. It forms the bigger part of tympanic membrane. It forms the stronger part of tympanic membrane. Pars flaccida is the smaller part of tympanic membrane. It is the upper part of tympanic membrane. It's a weaker part of tympanic membrane. The reason is tensa has got three layers: outer skin, inner mucosa, middle fibrous layer. But flaccida is flaccid because in this middle fibrous layer is almost absent. What is the separator between tense and flaccida? Roughly a line at the level of the lateral process of malleus, beta. Okay, fine. All of you draw a diagram on the side, beta. Why not draw a diagram in your own hands, with your own hands, beta? All of you draw a diagram with your own hands, beta. Just to make sure everything you know, okay? Oval in shape. Draw a diagram like handle of malleus, like this. Label it, beta. 1, 2, 3, 4. What is 1? Speak about it. What is 1? Handle of malleus. Very good. What is 2? Lateral process of malleus. What is 3? Umbo. What is 4? Cone of light. 1. Handle of malleus. 2. Lateral process of malleus. 3. Umbo. 4. Cone of light. From here to here, PT, and this part is PF. And this is right tympanic membrane. It's a 5 o'clock. Right tympanic membrane. Right tympanic membrane is 5 o'clock. Chal. This was about the normal tympanic membrane, stories. Let us go further, guys. Now, everybody, this much we're done now. Next concept, beta. Everybody go to the page number 95. 95, beta. Main function of eustachian tube is middle ear ventilation, beta. Please understand, what is the main function of eustachian tube is middle ear ventilation, beta. What do you mean by middle ear ventilation, beta? Let us understand it. Middle ear ventilation. Everybody focus on the screen, beta, right now. Everybody focus on the screen over here. Just see, beta. Now, where are we actually, first of all? This is EAC, external canal, and from outside the air is entering over here, beta. This is what? This is tympanic membrane. This is middle ear, beta. This is eustachian tube, beta. This is nasopharynx, beta. NPS, nasopharynx, okay. Now the same air is here also, no, beta? Air is here also. The air is also here also. The same air is entering from here, beta. Is entering the middle ear, beta. So, what is happening is, if this is tympanic membrane, both sides of tympanic membrane, equal air pressure is coming. On this side of tympanic membrane, external auditory canal is giving air pressure. On this side, eustachian tube, from nose to nasopharynx, air goes. From nasopharynx, please see, from nasopharynx, the air enters through the eustachian tube, and the yellow arrow, air enter the middle ear. And on both sides of the tympanic membrane, equal air pressure is there, beta. Okay, fine. Now, if eustachian tube is blocked due to any reason, there will be negative pressure in the middle ear, beta. Because air will not be able to enter from this side. When the air cannot enter from this side, means there is vacuum over here. What is vacuum technically called? Negative pressure. Negative pressure or vacuum sucks the things towards it, beta. Okay. Now read your notes, beta. Now read your notes. If ET gets blocked, it will lead to negative pressure in the middle ear. This leads to retracted tympanic membrane. Okay. One problem was glue ear. If eustachian tube is blocked, I know you have a question. If eustachian tube is blocked, glue ear, yesterday topic. Yes, glue ear can happen. But another thing is retracted tympanic membrane can also happen. I think one etiology can cause multiple disorders. Smoking can cause oral cancer, laryngeal cancer, lung cancer, bladder cancer also. Bladder cancer also for that matter. Okay. Similarly, eustachian tube blockage can cause glue ear, which we discussed yesterday, which we discussed today also. And it can also cause a negative pressure in the middle ear, which leads to retracted tympanic membrane. What is retracted? In the bracket, retracted in a simple language is sucked toward middle ear. Sucked towards middle ear. Retracted means sucked towards middle ear, beta. Sucked towards middle ear, beta. Okay, fine. Now, feature retracted tympanic membrane, it is dull in appearance, beta. Can you see that pearly shine is gone away And if you see, this is retracted tympanic membrane, and you can see in this also, it is appearing as if somebody has sucked it from backside, beta. It is appearing as if something has sucked it from backside. Retracted matlab sucked toward middle ear. What has sucked it? The negative pressure in the middle ear, beta. Why negative pressure? Because eustachian tube has got blocked, and the air was supposed to enter in the middle ear through eustachian tube only, beta. Okay, fine. Now, next one, beta. Retraction pocket. Next, retracted TM. Now, retraction pocket. Now, what does it mean by retraction pocket? If there is too much of retraction, it will lead to formation of retraction pockets. Beta. Too much of retraction will lead to formation of retraction pocket. कुछ ज़्यादा ही suck हो गया. Negative pressure behind the tympanic membrane has sucked the tympanic membrane, but too much of retraction will lead to formation of retraction pocket. The retraction pocket is most commonly seen in pars flaccida. The retraction pocket is most commonly seen in pars flaccida. Pars flaccida. Why? It's a weak part of tympanic membrane, beta. Always like the logic, beta. There's a sidebar used there, beta. Weak part. Guys, weak part can be sucked too much inside, nah? It's already weak, and behind that you put this vacuum. Don't think that vacuum can suck the pars flaccida too much. Too much of retraction will form a pocket, and that is called retraction pocket, beta. Now, retraction pocket is lined by skin. It is filled by keratin, beta. Retraction pocket is lined by skin. It is filled by keratin. Retraction pocket is lined by skin filled by keratin. Look at my hand, beta. Look at my hand. This is the outer cover of the tympanic membrane. What is it, beta? Skin. Skin, na? I'm the middle ear. I'm the middle ear. Outer side, external auditory canal. What is the outer cover of the tympanic membrane? Skin. Skin. Now, if the pocket forms out of this, beta. Now, look at this, beta. If a pocket forms out of this, what will happen is that there will be over here, what is lined by, retraction pocket is lined by what? Skin, na beta? Retraction pocket is lined by skin. Please see over here, beta. This is the outer cover of the, outer layer of the tympanic membrane, beta. Okay? This layer, beta. This layer I'm talking about. This layer is what? Skin layer, beta. Skin, na? Skin layer. Now, this is skin layer, beta. Okay? Now, if this is the outer layer is skin, and if this makes a pocket, this pocket will be lined by what? Pocket will be lined by what? Skin, na? And skin makes what? Dead skin, na? And this is called retraction pocket. And retraction pocket will be seen more commonly in the upper part of tympanic membrane, which is a weaker part of tympanic membrane. And that part is called pars flaccida. Now read your notes again. Too much of retraction will form retraction pocket. And retraction pockets are more common in pars flaccida. And retraction pocket is lined by skin. It is filled by keratin. Retraction pocket is lined by skin. It is filled by keratin, beta. Am I clear, beta? Fine. This is clear. All of you, please label it. This is retraction pocket, beta. This is retraction pocket. This one. Retraction pocket. Oh, this is pars tensa is okay. Flaccida has a gadda. Flaccida has a gadda, and this gadda is called retraction pocket, beta. This gadda is called retraction pocket. It is lined by skin, beta. This is skin. This is what? Keratin, beta. Retraction pocket is lined by skin. It is filled by keratin, beta. Too much of retraction will form the retraction pocket, beta. Okay? So, this gadda is called retraction pocket. It is lined by skin. It is filled by keratin. I hope it is clear to all. Okay. Now, please see on the screen, beta. Please see over here. Can you see retraction pocket in pars flaccida? It is lined by skin. It is filled by keratin. Everybody mark it. This is the retraction pocket, beta. This is the retraction pocket. Retraction pocket is where? Not here, beta. This is the retraction pocket. Chalo. Diagram is ready. Clear? Is it clear to all? Okay. So retraction pocket. Now next further, beta. Now next let's go further, beta. Next page, beta. Now let the story continues, beta. Picture abhi baki hai. The story is still evolving further. If retraction pocket is allowed to progress, there will be small perforation at the tip of the fundus of retraction pocket. There will be small perforation at the tip of the fundus of retraction pocket. Through this perforation, the skin start growing into the middle ear, beta. Through this perforation, the skin start growing in the middle ear, beta. All of you draw it, beta. This is skin. The skin start growing in the middle ear. This skin in the middle ear, presence of skin in the middle ear is called cholesteatoma. Presence of skin in the middle ear is called cholesteatoma. One day, the retraction pocket will rupture. And from the ruptured point of the retraction pocket, the skin will gain entry into middle ear. The skin in the middle ear is called cholesteatoma. And what is the color of cholesteatoma? It is pearly white in color. Skin is keratin, na? Keratin. It will make keratin, na? And the keratin is white in color, beta. Guys, please understand, retracted TM, retraction pocket. One day, retraction pocket will rupture and there will be perforation at the tip of the fundus of the retraction pocket. Through this perforation, skin will grow into the middle ear. Skin in the middle ear is technically called cholesteatoma. Today you understand. What is cholesteatoma? Cholesteatoma is not anything very difficult to understand. Skin in the middle ear is called cholesteatoma, beta. Okay? It is pearly white in color and this is the look of the cholesteatoma, beta. This is the look of the cholesteatoma, beta. Okay, cholesteatoma, beta. Okay, am I clear, beta? Fine. It's the look of the cholesteatoma, beta. Everybody, look at screen, everyone. Look at screen, everyone. Now see this story, beta. See this story, beta. What is this? This is normal tympanic membrane. What is this, beta? Retracted tympanic membrane. The story continues. What is this, beta? Retraction pocket. And finally, what it will make one day will be the cholesteatoma. Is it clear to all, beta? The story is like normal tympanic membrane, this one. Then comes the retracted tympanic membrane. Then story grows further. It forms the retraction pocket. And then one day it makes the cholesteatoma, beta. Is it clear to all, beta? Is the story clear to all? Normal tympanic membrane, eustachian tube got blocked, retracted tympanic membrane. Too much of retraction marks the retraction pocket. Retraction pocket ruptured and the skin started growing in the middle ear and this is called cholesteatoma, beta. Can you see this, beta? Everybody is clear? I'm just going to be out of the scene. You see. Can you see normal tympanic membrane number 1 picture? Then you see retracted tympanic membrane number 2 picture. Then retraction pocket and then cholesteatoma, beta. This is all the problem of eustachian tube dysfunction. Can you understand how important the eustachian tube is? Okay. Now, let us study eustachian tube, beta. Now, before that, one more thing, beta. Just add to your notes, beta. Add your notes. Just see on the screen, beta. You must have done it in earbuds, no? By chance, earbud goes inside. It damages your tympanic membrane and you will get a perforation, beta. Can you see a traumatic perforation, beta? Traumatic. Can you see the earbud has gone through and through the tympanic membrane and it has damaged the tympanic membrane. It has caused the perforation of tympanic membrane. And this is called traumatic perforation of tympanic membrane, beta. Am I clear? Fine. Chal. Traumatic perforation of tympanic membrane. Now, everyone, just add one line to this, beta. On the side, write down. Here only, you can write. Treatment of choice of traumatic perforation of tympanic membrane is conservative treatment. Means no treatment required. Conservative treatment, beta. Conservative. Give the nature a chance, beta. In the bracket, just keep ear dry. Just keep the ear dry, beta. No ear drops. Don't put any ear drop, beta. No ear drops. No ear drop, beta. No ear drops. No ear drops needed. That's the MCQ, beta. Traumatic perforation does not need any treatment, beta. Traumatic perforation will heal on its own in most of the cases. Just the treatment of choice is conservative treatment. Conservative treatment is MCQ, beta. Put a star. MCQ. Traumatic perforation of tympanic membrane. How to treat it is conservative treatment. Just keep the ear dry. No ear drop should be given even better. Okay, look at screen beta. Can you see it? The earbud went through and through, and the perforation happened beta. And the perforation happened. Earbud went through and through, and perforation happened over there. This is perforation happened. Okay, this one. And now, if you give time to nature, just keep the ear dry, it will heal better. Can you see the fresh perforation? And if you keep the ear dry for a few weeks, the perforation will heal totally better. Can you see? There is no evidence of perforation here better. Nature has already healed the perforation. You know, there is a complete chapter of wound and healing in pathology. Wound and healing is a big chapter in pathology, fibroblasts, etc., etc. तो मुझे लगता है वो पूरी कहानी है. It's a fiction. It's a fiction, beta. No, it's a reality. All these things can grow and cover the gaps, beta. Okay? So, this is the traumatic perforation. After a few weeks, it's a healed perforation without any treatment, beta. So, treatment of choice of traumatic perforation is conservative treatment, no treatment required. Just keep the ear dry. Don't even put any ear drops, beta. Okay? Chalo. Now, let's go further, beta. Next topic. The next topic is Eustachian tube, beta. Let us discuss Eustachian tube. By now, you know Eustachian tube is very vital for your ear, beta. Let's discuss few important points about Eustachian tube. We call it ET, beta. ET. It connects middle ear to nasopharynx. Yes, I remember middle ear to nasopharynx. Okay. Its nasopharyngeal opening lies 1.25 centimeter behind the posterior end of inferior turbinate. I hope you remember, right behind the nose is nasopharynx. What was choana? Anybody? What was choana? Choana was the posterior opening of nasal cavity. Behind the choana is nasopharynx. How behind is the Eustachian tube opening from the nose, beta? Look at the line, beta. Its nasopharyngeal opening lies 1.25 centimeter behind the posterior end of inferior turbinate. If you remember, the turbinates go till the end of the nose, beta. Okay? When the nose ends, turbinates end. 1.25 centimeter behind that area is the nasopharyngeal opening of the Eustachian tube. Okay? Now, how much is the length of it? It is 36 millimeter in length. 36 millimeter in length. Outer 12 millimeter is bony. Inner 24 is cartilaginous. It is 36 millimeter in length. Outer 12 millimeter is bony. Inner 24 is cartilaginous. Okay. At birth, it's nearly horizontal tube, beta. At birth, it's nearly horizontal tube. At birth, it is nearly horizontal tube. But in adults, it has 45-degree angle with horizontal. In children, it's nearly horizontal. But in adults, it has 45-degree angle with horizontal, beta. 45-degree angle. Anybody, what was the angle of tympanic membrane with horizontal? 55 degree. What is the angle of Eustachian tube with horizontal in adults? 45 degree. In children, there is no angle. It's horizontal, beta. Okay. The main function of Eustachian tube is middle ear ventilation. Middle ear ventilation, beta. The main function of Eustachian tube is middle ear ventilation, beta. We just wrote that. It sends air in the middle ear. The main function of Eustachian tube is middle ear ventilation, and also, I hope you remember, it also let the mucus of the middle ear come to the pharynx also. Okay? Okay, fine. Now, which muscle opens the tube, beta? MCQ. Tensor palati is equal to tensor villi palatini muscle. Tensor palati or tensor villi palatini muscle, beta. Tensor palati or tensor villi palatini muscle, beta. Tensor palati or tensor villi palatini muscle, beta. Okay, it opens the tube during swallowing. Whenever you swallow, look at me, you're swallowing at any given point of time. What are you swallowing? Saliva. Saliva, beta. We are unconsciously swallowing saliva very regularly, beta. So there's a very natural thing linked to that swallowing of saliva or food, even that matter. Whenever you swallow, the tube automatically opens and the air goes in the middle ear. So middle ear is continuously being ventilated. Don't worry about it. You need not do any conscious thing to ventilate your middle ear. It's connected to your swallowing beta. When you swallow, the tensor palati or tensor villi palatini muscle opens the tube actually automatically. Now this is 36 millimeter in length beta. Please see, it is the total length. Look at beta. This is 36 millimeter in length beta. 36. How much is total length? 36. But can you see beta? The outer 12 millimeter, this one. Outer 12 millimeter is bony. Which bone it is? Temporal bone. Don't forget. Every ear is nothing but temporal bone. Outer 12 millimeter is bony. But inner 24 millimeter is cartilaginous beta. So total length is 36 millimeter. Outer 12 millimeter is bony. But inner 24 is cartilaginous beta. Am I clear? Very good. Okay. Now, which muscle opens it? Tensor palati or tensor villi palatini muscle beta. Okay, beta. Chalo. Now, let us discuss the star topic of your exam, glue ear beta. We have discussed it multiple times in the pharynx also. Let us discuss from the ear angle now beta. Glue ear. Glue ear, first of all, is equal to SOM. Glue ear, nowadays we don't call it glue ear. The more popular name is serous otitis media. Look at the name beta. First line, glue ear is also called as serous otitis media or secretory otitis media. Look at the name beta. When you read, think carefully. Serous matlab non-infective. Serous, not suppurative. Suppurative matlab pus. Serous mane transudate. Just a non-infective fluid in the ear beta. Okay. Now it is collection of sterile. The keyword is sterile beta. Under the keyword, it is collection of sterile, thick glue-like fluid in the middle ear. Sterile, thick glue-like fluid in the middle ear beta. It's collection of sterile, thick glue-like fluid in the middle ear. Okay. Basic etiology is ET blockage. Basic etiology is ET blockage. Beta. We have been discussing since yesterday. If your second tube is blocked, the middle ear can get glue ear beta. Okay. The most common age is school age children. This is mostly a disease of school age children. Most common age is school age children. Beta. Most common age is school age children beta. Now, what are the causes of ET blockage beta? Number one, write down A and B beta. A and B. Most common causes adrenal hypertrophy causing ET blockage, mostly bilateral. If you remember, Eustachian tube blockage will be bilateral. Adenoid cause bilateral glue ear mostly beta. Adenoid is midline. It causes bilateral glue ear mostly beta. Yesterday class of pharynx beta. Adenoid mostly cause bilateral glue ear beta. Seen in school age children. Adenoid is a problem of school age children. I'm sure you would be remembering this picture beta of open mouth beta. Remember the child with open mouth beta. Adenoid face beta. So mostly adenoid story is linked with the glue ear story beta. And adenoid mostly cause bilateral glue ear. So always when you think like a doctor, the question come adenoid mouth breathing child with hearing loss beta. These children are looking like sort of little disturbed, and they've got a hearing problem also because adenoid is very commonly married to glue ear beta. Okay. So these two questions are integrated questions beta. Adenoid problem with glue ear problem. So treatment is also integrated actually. Now the rare cause beta. Both are star MCQ first of all. Rare cause is NPC, nasopharyngeal carcinoma, more common in China beta. NPC causing ET blockage, mostly unilateral. Unilateral, seen in adults. Mostly unilateral, seen in adults beta. Seen in adults. Mostly unilateral, seen in adults beta. Okay? Seen in adults. Am I clear beta? Adults. Okay. Can we go further? So I know mostly adenoid is the cause, and adenoid causes bilateral glue ear, seen in school age children. Rarely there can be a cancer which is uncommon in India, nasopharyngeal carcinoma, that causes this problem in adults, but it is unilateral. Clinical picture. Mostly school age child. Let us not forget this child. This is adenoid child. School age child complaining of heaviness in the ear. This child has got glue in the middle ear beta. Heaviness in the ear, and it's not a painful disease beta. This is MCQ beta. Is glue ear painful? No, it's not painful beta. Only heaviness in the ear beta. Why heaviness in the ear? Because this poor child has got something in the middle ear which is filling it, beta. Can you see over here? Middle ear, this tympanic membrane, behind that, can you see air bubble here? The air bubbles are trapped within the glue. This middle ear is full of glue-like fluid, beta. Okay? And this filled up fluid feeling in the ear will give heaviness in the ear, but it is not painful, beta. It's not infection. It's not painful. Only heaviness in the ear. Okay? Now, due to this glue-like fluid in the middle ear, can you hear properly? Not at all. There will be hearing loss, beta. There will be what type of loss? Conductive hearing loss, beta. Which leads to poor school performance, beta. Poor school performance. Poor school performance. Which lead to poor school performance, beta. Please understand it. When you can't hear properly, how can you take the dictation? Your teacher, you are second class student. This is second class student, beta. Second class student, and the teacher taking dictation. Teacher saying, write the spellings of mango. Mango, beta. She says mango. You are not able to hear mango because you have a hearing loss. And you say, probably she's saying tango. You say tango, T-A-N-G-O. Teacher says wrong. Wrong, 0 marks. You fail in the class. It's not that you are not intelligent. You are not able to hear properly. Because you are not able to exactly hear, did she say mango or tango? So you wrote tango. So you failed in the exam, beta. So poor school performance category, beta. Plus minus adenoid phase. Nobody would forget it. This adenoid story is married to glue ear story, but adenoid children are actually having glue ear very commonly. This is a doctor thing, beta. This is integration, beta. This question will surely come in the exam in one or other format, beta. Glue ear is such a popular topic that it is coming every now and then. Something or other is coming out of glue ear, beta. So imagine adenoid child like this kind of problem will have hearing loss also, beta. Okay. Examination. Glue-like fluid behind tympanic membrane. Air bubble trapped within the glue, beta. You just saw that there was a glue-like fluid behind tympanic membrane, and can you look at it, beta? This is the air bubble, beta. Air bubble trapped behind the tympanic membrane in the glue, beta. Okay, I can see the fluid level also, beta, over there. Now the next one, beta. Treatment is surgery. The surgery, Marringotomy. What is marring, beta? What is marring? All draw. Marring means tympanic membrane. Otomy means cut. To give a cut on the tympanic membrane. Can you see marringotomy, beta? Tympanic membrane, somebody is giving a cut on that, beta. Marringotomy. Marringotomy in which quadrant? In antero inferior quadrant. Marringotomy in which quadrant? Antero inferior quadrant. Antero inferior quadrant. Marringotomy in which quadrant? Antero inferior quadrant, beta. Okay. Plus grommet insertion. Plus grommet insertion. Grommet insertion, beta. This is grommet, beta. Grommet. This is grommet, beta. Grommet like which shape? Dumbbell shape, beta. Dumbbell shape. Dumbbell shape. It is very small, beta. Very small. It's like a rice grain, beta. Again a rice grain. It's very small. Look at me, beta. This it's not a very dumbbell. ऐसा नहीं dumbbell है. It's a small like this. This much. इतना सा छोटू सा होता है एकदम से. It's rice grain like, beta. Dumbbell shape, beta. So what do? You do the marringotomy. Can you see? You do give the cut on tympanic membrane. Marringotomy to give a cut on tympanic membrane. Then you put a suction there. You suck the glue out, and then you take the grommet, and in the same cut you put the grommet, beta. Can you see, beta? Can you see this white ring-like thing? This is one part of this, beta. This is this ring visible over there. The other part is inside, towards the middle ear side, beta. So whenever you see a white ring-like thing in the tympanic membrane, mark it what it is. It is grommet, beta. Grommet. Okay. How to remember it? Write on the side, beta. Write on the side. G for glue. Glue needs grommet. G for glue. Glue needs grommet. Grommet word will not come anywhere in the exam, beta. Only for glue ear or also called as serous otitis media. Remember, glue ear also called as serous otitis media. Glue needs grommet, beta. Glue मांगे grommet. Glue मांगे grommet, beta. Okay, बच्चे? Marringotomy with grommet insertion. Okay. Plus minus adenodectomy, beta. Yes. Plus minus adenodectomy also. Don't forget, never ever see adenoid and glue ear separate from each other. If the question mentioned mouth breathing child with hearing loss. Mouth breathing child, adenoid hypertrophy. Hearing loss, glue ear. Adenoid is very commonly combined with glue ear in the MCQs also. Mouth breathing child is a hint for the adenoid hypertrophy. Hearing loss is a hint for the glue ear, beta. So treatment is Maringotomy plus grommet insertion. Grommet is also called middle ear ventilation tube plus minus adenodectomy. Okay, beta? Fine. Just see on the screen, beta. Just see on the screen, everyone. Please see. This is the Maringotomy which has been done, beta. Maringotomy. Can you see? This is tympanic membrane. This is the cut on tympanic membrane. This is Maringotomy side. This is a suction tube. And this is the glue coming out of the middle ear, beta. Can you see? This suction is sucking the glue out of the middle ear. Now, please see. It's so thick, like a Fevicol, beta. You can make a long string out of this also, beta. If you're free in the operation theater, you don't do anything. Can you see it's a long string? Can you see really the glue, beta? Glue. Glue here is really like a glue, beta. Please see. Again, once again, see, beta. See, this is the Maringotomy done over there. Tympanic membrane is there. You gave a cut over here. This is Maringotomy. Then suction is sucking the glue out. Can you see? The glue is so thick. It's like a Fevicol, beta. Once you have done this one, then you do what? Then you put the grommet over there, beta. In the same hole, you put a grommet also, beta. What is this, beta? Grommet. Can you see white ring-like thing? Grommet, also called middle ear ventilation tube. In the same hole, you put what? Grommet. Do not worry. This within few months, nature is going to push it out, beta. You need not remove the grommet. Nature will push it out, beta. It will keep it for a few months and nature will push it out. This what is it, beta? In the same hole, you put what? Grommet. What is grommet? Middle ear ventilation tube, beta. Middle ear ventilation tube. Am I clear, beta? Fine. Perfect. So, Maringotomy with grommet insertion. Glue needs grommet, beta. I hope you're clear about it. I hope you're learning. I hope you are enjoying the day. My concern is not, finishing ENT. My concern is that you should become informed physician about ENT topics, beta. Later on, when you go open your practice, you should be knowing when some doctor writes, plan is Maringotomy grommet insertion. You should know about it as a doctor. Okay? Fine. Chalo. Next one, beta. Next topic. Middle ear. Everybody, open up the next topic. Middle ear, beta. Middle ear. Now, middle ear, it's also called as tympanum. Middle ear is also called as tympanum. Tympanum. Now, Maring, tympanic membrane. Tympanum, middle ear. Please understand. Maringoplasty is the middle ear surgery or tympanic membrane surgery. Tympanoplasty is middle ear surgery. So, whenever you see word Maringotomy, Maringoplasty, think of tympanic membrane. When you say tympanotomy, tympanoplasty, tympanometry, think of middle ear, beta. Now, middle ear is a hollow cavity in the temporal bone. I already told you, ear is nothing but temporal bone, beta. External ear, middle ear, inner ear. So, you finished the external ear. Now, let us start the middle ear. Let us go behind tympanic membrane now. Okay. Now, middle ear has three parts, beta. Write down M, E, and H. Mesotympanum, epitympanum, hypotympanum. Meso means middle part. Epi means upper part. Hypo means lower part. Write down in the bracket. Meso is middle part. Epi, upper part. Hypo, lower part. Middle part, lower part, upper part. Middle part, lower part, upper part. Of course, epi means upper part, hypo means lower part, meso means middle part. Not a big deal, beta. But just to make it clear, beta. Everybody look at me, beta. Look at me, everyone. This is your middle ear. How to understand this soon? This is your middle ear, beta. This is your middle ear. This is the middle ear. Now, this is your tympanic membrane. Tympanic membrane. Tympanic membrane does not cover the middle ear fully. It covers majority of it, beta. Okay. Now, look at this. This is tympanic membrane. Tympanic membrane is not that big that it can cover the middle ear fully, beta. Middle ear is bigger than tympanic membrane. So, middle ear covers majority of tympanic membrane. The tympanic membrane covers majority of the middle ear. The part of the middle ear which is covered by tympanic membrane is called mesotympanum. Look at my finger, beta. The part which is left above is called epitympanum. The part which is left below is called hypotympanum. Epi and hypo are covered by bone. Which bone? Temporal bone. Epi and hypo are covered by bone. There is a bone cover here, the bone cover here, beta. So, my finger are the epitympanum. My thumb represents the hypotympanum, and this is the mesotympanum. So, mesotympanum is that part of middle ear which is covered by the tympanic membrane, beta. Now, look at your notes, beta. Mesotympanum is covered by tympanic membrane. Mesotympanum is covered by tympanic membrane. Okay? Okay? covered by tympanic membrane. It is the middle part of middle ear. It is a major part of middle ear, beta. It forms the, in the bracket, major part. The majority part of middle ear is mesotympanum, beta. Okay, bache? Fine. Then comes the epitympanum. Epitympanum also called as attic, beta. It is covered by bone called scutum, S-C-U-T-U-M, MCQ, beta. Attic is the question. You should know attic. I hope you know English meaning of attic. Attic means upper part of your house, beta. You know attic of the house, upper part of the house, attic. Attic means upper part of the middle ear, attic. Epitympanum is also called attic. It is covered by bone which is called scutum. Scutum, beta. Everyone look at screen, beta. Now please look at there. This is your external auditory canal, tympanic membrane. Okay, beta. External auditory canal, tympanic membrane, beta. Can you see middle ear from here to here is middle ear? This is mesotympanum. This is what a epitympanum. It's covered by bone called scutum, beta. This is scutum. Okay, label it, beta. This is scutum, beta. Everybody, this is your scutum, beta. Label it scutum, beta. Scutum label karo. This external auditory canal, label it. Of course, this tympanic membrane. Okay, this is inner ear, beta. This is middle ear. Epi, meso, hypo, beta. Epitympanum is upper part of middle ear. It's also called attic. It's covered by bone called scutum. Have you labeled it? Have you labeled it, beta? Okay. Am I clear? Fine. Very good. Okay. Chale aage, beta. Fine. Now, let's go further, beta. Hypotympanum is also covered by bone. Can you see hypotympanum? Is also covered by bone. There is no name of that bone, beta. It's unnamed bone, beta. Main thing is scutum, beta. Scutum is the bone which covers the epitympanum, also called as attic, beta. Attic is the other name of epitympanum. It is covered by bone called scutum. Nobody will forget the scutum word, beta. S-C-U-T-U-M. S-C-U-T-U-M, beta. Now, depth of middle ear, beta. Epitympanum 6 millimeter. Meso to hypo 4, beta. 6 to 4, beta. 6 to 4. So mesotympanum is the narrowest part of middle ear. Epi is the deepest part of middle ear. I'm not saying the largest size, but size wise, of course, please see, I'm largest sizes. Meso is the biggest part of the middle ear, beta. Mesotympanum is the biggest part of the middle ear. I'm not saying the size, beta. Length wise, length, of course, this is biggest, beta. But depth wise, depth, मतलब this distance, beta. Depth, this distance, depth. Meso is little narrow part. Epi is little wide part, beta. Epitympanum is the widest part of middle ear, beta. Okay, 6 to 4, beta. Very good. Now, let's go to the next topic. Sensory supply of middle ear. Doctor, मेरे कान के अंदर दर्द हो रहा है. I have pain right in the deep of my ear actually. Sensory supply of middle ear is by tympanic branch of glossopharyngeal nerve. Ninth nerve, beta. Ninth nerve, beta. Try to recall ninth nerve. Yesterday also it came. Glossopharyngeal nerve was in the bed of the tonsil, beta. Oh, it was in the bed of the tonsil. Okay, fine. Remember, in the bed of tonsil there is what? Styloid process, and which nerve? Glossopharyngeal nerve. Okay, and this the same nerve gives a branch to the middle ear. What is tympanum, beta? What is tympanum? Tympanum is the middle ear, beta. Tympanic matlab middle ear branch of the glossopharyngeal nerve, also called as Jacobson's nerve, beta. Jacobson's nerve. Okay, now rhaphidotalgia mane earache, beta. Earache. Earache referred from somewhere else, beta. The ear is normal. Ear is normal, but pain is in the ear. Some other structure is referring the pain to the ear, beta. Ear. Okay. Now, very important. Tonsillectomy. Now, this is the MCQ possible in your exam, beta. Why tonsillectomy causes pain in the ear? Why? Which nerve lies in the bed of tonsil? Ninth nerve. Which nerve supplies the middle ear? Ninth nerve. Same nerve supplies the tonsil, same nerve supplies the middle ear. That's why pain of the tonsil is referred to the pain of the ear actually. Okay? Tonsillectomy. Tonsillitis. Tonsillitis, beta. Styalgia. Remember eagle syndrome, beta. Write down eagle. Try to recall, beta. Eagle syndrome. Yaad hai, beta? Visual, pictorial. Eagle. You remember eagle was holding the snake. The snake was what? Ninth nerve, beta. What is ninth nerve? Glossopharyngeal nerve, beta. Okay? And cancer of base of tongue. These all things cause earache via ninth nerve, beta. Which nerve? Ninth nerve, beta. Now please do not forget tonsillectomy, beta. Tonsillectomy causes earache via ninth nerve. Nobody will forget this one, beta. Extra information. You want to remember it, you can remember it, but nobody will forget. They will make a story. The child underwent tonsillectomy today. Tomorrow, the child started crying with the ear pain. Which nerve is responsible for referred earache? The answer is ninth nerve. Because I know as a doctor, anatomy also now, that tonsil bed has got ninth nerve and middle ear is supplied by tympanic branch of the ninth nerve only, beta. Okay. Now, one more advanced question. Supraglottic cancer and piriform sinus cancer. Yeah, it came day before yesterday also. Supraglottic, laryngeal cancer. Supraglottic, if you revise supraglottic cancer, the first symptom was throat pain referred to ear. Okay, piriform sinus came yesterday, part of hypopharynx, beta. They cause earache through which nerve? 10th nerve, beta. Vagus nerve, beta. Vagus nerve. Try to recall. Larynx is supplied by vagus nerve, beta. RLN, SLN branches of vagus nerve, beta. And ear is supplied by auricular branch of vagus nerve, beta. Try to recall, beta. You wrote in the exonotrical nerve supply, the ear is supplied by auricular branch of vagus nerve. And larynx is supplied by vagus nerve, RLN, SLN branches of vagus nerve, beta. Just apply your mind, beta. When you revise supraglottic cancer, it will be written throat pain referred to ear. Throat pain referred to ear through which nerve? 10th nerve, beta. But which question I would request you to not forget is tonsillectomy, beta. बाकी सब extra information के चक्कर में main बात ऐसा ना दिमाग. Tonsillectomy causes earache through glossopharyngeal nerve. Tonsillectomy causes earache through glossopharyngeal nerve, beta. Glossopharyngeal nerve. Tonsillectomy causes earache through glossopharyngeal nerve. Nobody will forget this one, beta. Chalo, beta. Now, the next topic, beta. 6 walls of middle ear, beta. 6 wall of middle ear, beta. Next topic, everybody open up. 6 wall of middle ear, roof of middle ear, floor of middle ear, anterior wall, posterior wall, lateral wall, medial wall. Lot of time I was confused in my MBBS days that what is the roof, what is the floor, what is the anterior wall, what is the posterior wall. Jacket to okay, roof, वो कहाँ है उसको भेजना है वो जो थोड़ा पतला वाला क्या है ना हाँ लाल जी को भेजो roof, floor, anterior wall, posterior wall, medial wall, lateral wall. Let us see on Lalji that what is the roof, what is the floor, what is the anterior wall, posterior wall, medial wall, lateral wall. देखो तो कितना कुछ लिखा हुआ है बेटा, है ना? पहले समझ आएगा तभी तो हम पढ़ पाएंगे, है ना? इसको सारे को समझ के करेंगे, समझ के याद करना है, याद तो करना है, समझ के याद करना है. ऐसे नहीं रट्टा नहीं मार लेना बिल्कुल. You know what? एकदम स्पाइनल लेवल पे नहीं. Understand it, memorize it. Without memorizing, understanding is useless. Let me tell you, write on the wall in your room. You understand it very well. It's of no use till the time you memorize it better. Understanding is a good thing, important thing. But memorizing is the end result of hard work. 2 times, 3 times, 4 times. Then only you will be able to recall that thing in the exam better. So make sure that you're not really, having this thing that, okay, you are just understanding something very nicely. You understand the whole, can say something like a respiratory physiology, but you did not, revise it, then what's the purpose of this? Okay. So let's understand the anterior wall, lateral wall, posterior wall and all that. Now we have Lalji. Thank you very much, Lalji. Lalji, come here. Now please see. Now, first of all, this is the ear. This is the roof of the ear. Beta. Above the roof of the ear is brain. Which part of brain? Temporal lobe of brain. Beta. So, roof is clear. Beta. Roof is towards the brain side. Above the roof of the ear is the temporal lobe of the brain. Beta. Now, this is floor. Floor. Below the floor is the neck. Neck. Okay. Roof is towards the brain side. Floor is towards the neck side. Itna clear ho gaya? Now come the anterior wall and posterior wall. Now look at me, beta. Anterior wall is towards mandible. All of you, please see. Anterior wall is towards mandible side. Posterior wall is towards the mastoid side, beta. I repeat, anterior wall is towards the mandible side. Posterior wall is towards the mastoid side, beta. Anterior wall, mandible side. Posterior wall, mastoid side, beta. Now we are left with medial wall and lateral wall, beta. Lateral is the outer wall. Look at towards you. Lateral wall is outer wall. What is the lateral wall? Tympanic membrane. Lateral wall is tympanic membrane, outer wall. And the medial wall, look at my hand, brother. If this is lateral, this is medial, lateral and medial. Lateral is the tympanic membrane. What about medial? Medial is that wall behind which lies the inner ear, beta. Please see, external ear, middle ear, inner ear, beta. Okay, lateral wall is tympanic membrane. Medial wall is that wall behind which lies the inner ear, beta. Medial matlab towards inner side. Behind the medial wall lies which ear? Inner ear, beta. Now please see. Okay, again see, beta. Roof and floor. Roof towards brain, floor towards neck. Anterior wall, posterior wall. Anterior wall towards the mandible, posterior wall towards the mastoid. And lastly, lateral and medial wall. Lateral, outer wall, tympanic membrane. Medial wall is that wall behind which lies the inner ear, beta. Am I clear? Thank you, Lalji. Now, everybody, let us discuss the sixth wall of middle ear, beta. Let us discuss it one. Number one, roof. Roof, above it lies dura of temporal lobe of brain, beta. Oh, I know that. कान के ऊपर brain होता है. Above it lies dura of temporal lobe of brain. Now, below the floor lies jugular bulb. Now, what is this jugular bulb, beta? Below the floor lies jugular bulb. Above the roof lies brain, temporal lobe of brain. Below the floor lies jugular bulb, beta. Below the floor lies jugular bulb. Everybody draw a diagram here, beta. You have a next page, you have an empty space. All of you draw a diagram with me, beta. Please see, this is your middle ear, mastoid. Middle ear, mastoid. I told you mastoid is a part of the ear, beta. Okay. Above the ear, draw the dura or brain, beta. Above the ear is brain, beta. Okay. Brain or dura of the brain, temporal lobe of brain, beta. Now behind, this is called sigmoid sinus. Sigmoid sinus, beta. Sigmoid sinus. Okay. There is a foramen here which is called jugular foramen. Jugular foramen is at the skull base, beta. Jugular foramen is at the skull. Jugular foramen. Then comes the neck. After jugular foramen, you come down in the neck, beta. This is neck. In the neck, this is called IJV, internal jugular vein. And this dilatation is called jugular bulb, beta. This jugular bulb, beta. Jugular bulb. This is the venous flow of the brain, beta. This is the venous drainage of the brain, beta. Venous drainage of the brain. Can you see the flow of the venous flow of the blood going down to the heart, beta? So please understand, sigmoid sinus, jugular bulb and IJV are nothing but different names of same structure at different places. I repeat, sigmoid sinus continues down as jugular bulb and jugular bulb continues down as internal jugular vein. Actually what happens is, sigmoid sinus is going to pass through the jugular foramen to continue in the neck as internal jugular vein, but before passing through jugular foramen, it gets dilated to form a bulb called jugular bulb, beta. It's very clear in this diagram, beta, for neuroanatomy also, that internal jugular vein is nothing but downward extension of sigmoid sinus. I repeat, beta, for neuroanatomy, as a doctor you should know, internal jugular vein is the downward extension of sigmoid sinus, beta. Internal jugular vein is a downward extension of sigmoid sinus. These all blue arrows are indicating the final venous return of the brain towards the heart. I learned today that sigmoid sinus, jugular bulb and internal jugular vein are nothing but different names of same structure in three different areas. I learned today that internal jugular vein is a downward extension of the sigmoid sinus of the brain. This is the final venous drainage of the brain towards the heart, beta. I learned couple of things more over in the diagram, beta. The concepts. Above the ear is the brain, behind the ear is sigmoid sinus, and below the ear is jugular bulb. I repeat the concept, beta. Above the ear is the brain, the dura of the brain, beta, and below the ear is jugular bulb, and behind the ear is sigmoid sinus, beta. Look at this concept, beta. This concept, beta, please important. This is important to remember. Above the ear is the brain, below the ear is jugular bulb, and behind the ear is sigmoid sinus, beta. Am I clear, beta? Is it clear to everyone? Above the ear is brain, below the ear is jugular bulb, and behind the ear is sigmoid sinus. Okay, this was about the roof and floor, beta. Let us do the next one, beta. Come to the third wall, anterior wall. We have done the number 1 roof, number 2 floor. We are studying anterior wall, beta. Anterior wall. Anterior wall means towards mandible side, beta. Mandible side. This wall has 2 openings. 2 openings, beta. A, B. Lower opening is for Eustachian tube, ET. Upper opening is for tensor tympani muscle, TT. Write down ET, TT. Lower opening is for ET, upper is for TT. ET, TT, ET, TT. Lower opening is for Eustachian tube, upper opening is for tensor tympani muscle, which is attached to malleus, beta. Tensor tympani attached to malleus, beta. Malleus. Tensor tympani attaches to which ossicle? Malleus. Okay. And this muscle is supplied by mandibular division of trigeminal nerve. How to remember? TT dot T, beta. Tensor tympani trigeminal. How to remember is tensor tympani trigeminal. TTT. Tensor tympani trigeminal. This muscle is supplied by mandibular division of trigeminal nerve. Mandibular division of trigeminal nerve. So anterior wall has 2 openings. How to remember? ETTT. Make it interesting, beta. Make it interesting, अगर boring हो जाता है ना? Anterior wall has 2 openings. ET lower opening, about TT. ET is Eustachian tube, upper is tensor tympani that attaches to malleus, and tensor tympani is supplied by mandibular division of trigeminal nerve. Okay. Now, then comes the posterior wall. Posterior wall has a projection called pyramid. Pyramid is the MCQ, beta. Pyramid is on which wall of middle ear? Posterior wall, beta. How to remember? Pyramid. Pyramid is from our past, beta. Pyramid is past of the humankind. Past. Pyramid, Egyptian pyramid, they represent our history, past of humans actually. Past मतलब posterior. Past, posterior. पीछे वाला. Posterior. Past, posterior. Back side. है ना? So pyramid is on which wall? Posterior wall. Okay. From pyramid, which muscle comes out? Stapedius muscle comes out, and that attaches to stapes. Attaches to stapes. This muscle is supplied by facial nerve. Stapedius muscle is supplied by facial nerve, beta. Stapedius is supplied by facial nerve, beta. Okay, facial nerve. Stapedius is supplied by facial nerve. Very, very important question. Pyramid, beta. Pyramid, from pyramid, which muscle comes out? Stapedius, and that attaches to stapes, beta. And stapedius is supplied by facial nerve. Stapedius is supplied by facial nerve, beta. Okay. Stapedius is supplied by facial nerve, beta. Everybody, try to look at this diagram, beta. If I may. Yeah. Now please see, this is the anterior and posterior wall of middle ear, beta. This is the anterior wall, posterior wall. Anterior wall, posterior wall. Posterior. Which one? This is the anterior wall and this is the posterior wall, beta. First of all, look at the anterior wall, beta. Now, everybody, where is the anterior wall? First of all, this is the anterior wall, beta. Anterior wall. That's the anterior wall. Okay. Now, anterior wall has 2 openings, beta. Number 1 opening and number 2 opening. Number 1 opening is for ET. What is ET, beta? What is ET, everybody? Eustachian tube, beta. This is what the number 1 opening is, ET. What is ET? Eustachian tube. And number 2 is TT. Can you see a muscle here, beta? Tensor tympani muscle. Please see on the beta. Please see on the screen, beta. Please see on the screen. The anterior wall has 2 openings. The lower opening is for ET, upper is for TT, and tensor tympani attaches to which ossicle? Malleus. Tensor tympani attaches to which ossicle is malleus, beta. Which ossicle? Malleus, beta. Malleus. Okay? Am I clear, beta? Now let me go to the posterior wall, beta. Let me go to posterior wall. Now this is the posterior wall, beta. Posterior wall. Let me take you close to it, beta. Okay. Can you see on the posterior wall, this wall, there is a projection here. This projection is called pyramid, beta. Pyramid. Pyramid. Okay. From pyramid, which muscle is coming? This muscle is coming. From pyramid, which muscle is coming? From pyramid, this muscle is coming, beta. This is stapedius muscle, beta. Stapedius muscle. And it attaches to what, beta? It attaches to stapes, beta. Okay, stapes. Can you see stapes, beta? Can you see, beta, posterior wall? This is the posterior wall, beta. Posterior wall has a projection called pyramid. Let me take you close to it, beta. Can you see posterior wall has a projection called pyramid? From pyramid, which muscle comes out? Stapedius. Attaches which ossicle? Stapes, beta. Pyramid on the posterior wall. Which muscle comes out? Stapedius. Attaches to stapes, beta. Now, please see on the screen, beta. Let us make it simple. Now, anterior wall, posterior wall. Anterior wall has two openings. The lower opening is for Eustachian tube, upper opening for tensor tympani muscle. It attaches to malleus, beta. Now posterior wall, this wall, beta, it has a projection called pyramid. This is a pyramid. Posterior wall has a projection called pyramid. From pyramid, which muscle comes? Is the stapedius that attaches to stapes, beta. This is which ossicle, beta? Incus, beta. Write down on the side, write down. Incus has no muscle. Incus has no muscle, beta. Only one muscle for malleus, one muscle for stapes. Incus, please see, incus has no muscle, beta. No muscle. Incus has no muscle at all. Okay, incus has no muscle. Now, again see on the screen, beta. Why you need muscles, beta? Why you need muscles? Please see. There is your ossicle, malleus, incus, stapes, beta. Why you need muscle, beta? Why you need muscle? Look at me, beta. Why you need muscle? Look at me, beta. You are sitting in the middle here. I throw three ossicles at you. Don't you think so? There is gravity, beta. They will fall in the middle here. How these ossicles are standing in the air, beta? They're standing in the air, beta. Why don't they fall downwards? Because something has to hold them. From anterior wall comes tensor tympani, it holds the malleus. From posterior wall comes the stapedius muscle, it holds the stapes. Incus is already sandwiched between the malleus and stapes, so incus does not need any muscle, beta. Incus is already sandwiched between the malleus and stapes, so incus would not need any muscle. Am I clear, beta? So basically these muscles are going to stabilize the ossicles so that they don't fall downward. One muscle for malleus, one muscle for stapes, but incus does not have any muscle, beta. Am I clear? Chal. Now let us go further, beta. Next one is the lateral wall. Lateral wall, the fourth wall, is made of tympanic membrane. Of course, lateral wall. Lateral wall is made by tympanic membrane, beta. Lateral wall is made by tympanic membrane. Let me show you the lateral wall. Lateral wall is made by tympanic membrane. Just see on the screen, beta. Everybody please see on the screen. This is your middle ear, beta. Where is the middle ear? This is your middle ear, beta. This whole thing is your middle ear. Can you see? Malleus, incus, stapes. Okay. Now, this is your external auditory canal. This is your tympanic membrane. This is your inner ear, beta. Okay. Fine. Fine, beta. Now, this is the lateral wall of the middle ear. Lateral wall. This is the medial wall of middle ear. Lateral wall is of course tympanic membrane, and medial wall is that wall behind which lies the inner ear, beta. Very simple, beta. Lateral is towards tympanic membrane and medial is that wall behind which lies the inner ear. Okay. Now, can you see, beta, inner ear is hidden behind the medial wall. Now, inner ear wants to show off that I'm also there. So, inner ear creates few projections on the medial wall of middle ear, because behind the medial wall lies the inner ear. So, this inner ear is going to create some projections on the medial wall of middle ear, and those projections are important to remember, beta. Now, open up your notes, everybody. Lateral wall is tympanic membrane, fifth wall. Medial wall, behind this wall lies the inner ear, beta. Medial wall, behind this wall lies the inner ear. Medial wall has two projections of inner ear. A, MCQ, promontory. MCQ beta. Promontory is projection of basal turn of cochlea. Promontory is projection of basal turn of cochlea beta. You know cochlea, inner ear, that creates a projection. Which part of cochlea? Basal turn of cochlea beta. Projection of basal turn of cochlea. You might say, Rajiv, where is the cochlea? I'll show you beta. Just see on the screen beta. No problem. Can you see beta over here, everybody? This star beta. This star is the basal turn of cochlea beta. This star is basal turn of cochlea. Can you see it's making a projection on the medial wall? Can you see this wall is projected, is lifted upward, and this projection is called promontory beta. Don't confuse promontory with pyramid beta. Pyramid was a posterior wall. Beta. Pyramid past posterior wall. Promontory is the projection of basal turn of cochlea on the medial wall of middle ear. This is basal turn of cochlea is making a projection on the medial wall, and this projection is called promontory beta. Am I clear beta? Promontory. Number 2. Can you see there are canals also beta? You know, we'll read inner ear. Inner ear got canal also, na? Canal, semicircular canal. So those canal also make a projection beta. Number 2 beta. Number 2. Number 2 is lateral semicircular canal projection called lateral SCC bulge. So two things make a projection. One is cochlea, other is lateral semicircular canal, which is called lateral SCC bulge. What is SCC? Semicircular canal bulge means projection. Okay. So promontory and lateral SCC bulge. Promontory is the MCQ beta. So which canal makes the bulge on the medial wall of middle ear? Lateral semicircular canal, which is a part of inner ear beta. So two projection of inner ear, one is of cochlea called promontory, other of the canal called lateral SCC bulge beta. Now, medial wall also has two windows for the inner ear. I'm sure you know what is the name of two windows. Oval window, round window. Okay, oval window and round window beta. I'm sure you know it. You know, the medial wall has got two window also beta. Can you see? Everybody look at the diagram. Where are we? This is what beta? External auditory canal, tympanic membrane, middle ear, inner ear beta. This is oval window, this is round window beta. Oval window, round window beta. Oval window, round window. Can you see beta? Oval window, round window. Look at this beta. Oval window, round window, where they are? On the medial wall of middle ear. Behind this wall lies the inner ear beta. Oval window is covered by foot plate of stapes. Remember, stapes foot plate is lying at oval window of cochlea. So medial wall of middle ear has got two windows for the inner ear beta. Is the inner ear. Oval window is covered by foot plate of stapes. Round window has got nothing but a membrane called round window membrane. This membrane called round window membrane, also called as secondary tympanic membrane. Okay beta. Oval window is covered by foot plate of stapes. Round window is covered by round window membrane, also called as secondary tympanic membrane. Secondary tympanic membrane is the multiple choice question beta. Now please see, oval window is covered by foot plate of stapes. Round window is covered by round window membrane, also called as mark beta secondary tympanic membrane. Secondary tympanic membrane is other name of round window membrane. Write down secondary tympanic membrane. Secondary tympanic membrane is other name of round window membrane. Lot of question in this table beta. Okay, bache? Can we revise it beta? Everybody, let's revise this whole paper beta. Everybody, basic concept. Everybody speak with me. Above the roof of the ear lies brain. Behind the ear lies sigmoid sinus. Below the ear lies jugular bulb. So above the roof is dura of the temporal lobe of brain. Below the floor is jugular bulb. Behind the ear is which sinus? Sigmoid sinus beta. Now anterior wall has two openings. ET, TT. Remember, rhyme it beta. Make it interesting. ET, TT. ET lower opening for you take into TT for tensor tympani, which attaches to malleus. Then posterior wall has a projection called pyramid. Posterior wall. Posterior means past. Past is pyramid is our past beta. Egyptian pyramid past. From pyramid which muscle comes? Stapedius for stapes. Incus has no muscle. Lateral wall is tympanic membrane. Medial wall, behind this medial wall lies inner ear. This wall has two projections of inner ear, two windows for the inner ear. Two projections are number one promontory, which is a projection of the basal turn of cochlea, and number two lateral semicircular canal bulge. Two window are oval window, which is covered by foot plate of stapes. Round window is covered by round window membrane, also called as secondary tympanic membrane. Okay? Nobody would memorize anything as of now. Understand and get familiar with the notes. Beta. Later on, we'll revise it. As of now, just understand, bro. Just make impression in your heads, beta. Okay, that's important. Don't overwhelm yourself. Don't get, oh, ये भी याद रखना, वो अभी कुछ नहीं. Just get used to what is written where in the workbook and try to imagine with me what we are really going through, beta. Now, everyone, let us discuss the next topic, beta. Everybody open up middle ear cleft, beta. Everybody open up middle ear cleft. Middle ear cleft, beta. Middle ear cleft now. Everybody first understand middle ear cleft. Everyone, middle ear cleft. Now, can you tell me ear lies in which bone? Temporal bone. Middle ear is nothing but a hollow cavity in temporal bone. Itna clear ho gaya beta? I hope by now you are clear that ear, external ear, middle ear, inner ear are temporal bone beta. Middle ear is nothing but hollow cavity in temporal bone. But in the temporal bone, there are many other hollow cavities apart from middle ear. All the hollow cavities of temporal bone combined together are called middle ear cleft. Look at the first line. Middle ear cleft is a combination of all hollow cavities in temporal bone. Middle ear is a hollow cavity in temporal bone, but there are many other hollow cavities in temporal bone. All the hollow cavities of temporal bone combined together are called middle ear cleft. I told you yesterday, we said sinuses. Our skull is a hollow, structure. We had sinus, maxillary sinus, frontal sinus. Similarly, temporal bone has got many hollow cavities. One of them is middle ear, beta. Okay? Even Eustachian tube is also part of the temporal bone, beta. It has 5 parts. Number 1, Eustachian tube, middle ear, adductus, antrum, and rest of the ear cells. Let's understand it. Everybody draw a diagram with me, beta. You have a space here, or maybe you can draw a small diagram here, beta, with me. Just a small diagram here. Just see over here, beta. This is your middle ear, Eustachian tube, mastoid. We are drawing temporal bone, beta. Okay, all of you draw this, the petrous part of temporal bone. This is the mastoid part of temporal bone. This is called the petrous apex. The end of temporal bone is called petrous apex, beta. Petrous apex. There are many cells. The large cell is called antrum. There are many other cells in the mastoid, just like ethmoid cell. You remember yesterday class, ethmoid, beta? Okay. Antrum is a big cell, is the constant cell. And similarly, whole of temporal bone is full of air cell, air cell, air cell. Like yesterday we had ethmoid air cell. We have got today temporal bone air cell, beta. Now, antrum is connected to middle ear through a channel, and that channel is called adductus. Adductus, beta. Adductus connects antrum to middle ear, beta. Adductus connects antrum to middle ear. Adductus connects antrum to middle ear, beta. Okay. Now, at the petrous apex, please to draw 2 nerves, beta. These 2 nerves are 5th and 6th nerves. Trigeminal and abducens nerve lie very close to the petrous apex, beta. Petrous apex. Okay, bache, fine. Done, beta. Okay. Chal. Now let us start, imagining it further, beta. Everybody, look at screen, beta. This is your temporal bone, beta. This is your mastoid part of temporal bone, like this one. There are many cells in that. This antrum is largest cell, then small cell. This is middle ear here, and they are connected by a channel called additus, beta. Am I clear, beta? Just to imagine really what is happening there, beta. Additus. Am I clear, beta? Additus. Oh, sorry, antrum, beta. This is antrum. Antrum is the largest cell. It's connected to middle ear through a channel called additus. Inside there is a connection between middle ear and antrum, and that channel is called additus. Is it clear? This is a hollow bone, beta. Similarly, see this one, beta. See this one. This is your petrous part of temporal bone, and this area is called petrous apex, beta. Let me draw with other color. This area is called petrous apex, beta. This area is called petrous apex, beta. This is petrous apex, beta. This is the petrous apex. Okay. Now this also has got many air cell, beta. This is also temporal bone, na? This is petrous apex, beta. Okay, bache? Fine. Now, at petrous apex, we have two nerves, beta. We have two nerves. Which two nerves? Fifth nerve and sixth nerve, beta. Both sides, na? Fifth, sixth nerve. Which two nerve enter the ear from here? Seventh nerve and eighth nerve, beta. I hope you remember, beta. Seventh nerve, facial nerve, passes through the ear, comes out. Eighth nerve supplies the inner ear, finishes it. Can you maintain the continuity of thought? 5, 6, 7, 8. 5 trigeminal, 6 abducens, facial, vestibulocochlear. From brain. Brain is here, beta. So 5, 6, 7, 8, beta. So try to create an imagination, beta. This area is called petrous apex, my dear friends. This area is called petrous apex, beta. This is the petrous apex, beta. One on this side, one on this side, beta. Very close to brain, beta. Brain is here. This whole is brain, beta. That's here, beta. Am I clear, beta? So this whole bone is temporal bone, is full of air cell. And now look at your diagram, and you have drawn that. Okay, this is the petrous part of temporal bone. Na? This is the mastoid part of temporal bone. Now read your notes, beta. Now read your notes, everyone. Please see your notes, beta. Okay, please see. Antrum is the largest and most constant mastoid air cell. Look at the line, beta. Antrum, it is the largest and most constant mastoid air cell. Everybody, can you tell me yesterday in the ethmoid bone, we said that there is one anterior ethmoid air cell which is constant and the largest anterior ethmoid air cell, and we call it BE. What was BE? Bulla ethmoidalis. Bulla ethmoidalis, beta. Bulla ethmoidalis, beta. Okay. Remember yesterday we labeled that cell of ethmoid which was constant and largest as bulla ethmoidalis. Today we are saying that mastoid has got one cell which is constant and largest, and that cell is called antrum, beta. Okay. It's connected to middle ear. Antrum is connected to middle ear through additus, beta. ADITUS. Additus. Additus, beta. Antrum is connected to middle ear through additus, beta. Okay. Now read, beta, over here. It has 5 parts. Beta. Number 1, Eustachian tube, then middle ear, additus, antrum, and rest of your cell. It's easy, beta. Start from Eustachian tube, go to middle ear, then additus, then antrum, then rest of all ear cells, beta. Rest of all ear cells, beta. Eustachian tube, middle ear, additus, antrum, and rest of ear cells. Now next line, beta. Read carefully. All these hollow spaces are mucosa lined and are interconnected. These all cells are interconnected, but they're one part of one system. But can you see? This is Eustachian tube, middle ear, additus, antrum, and rest of ear cells. All these are interconnected system, beta. All are interconnected and mucosa lined also. Like sinuses are mucosa lined. These cells are also mucosa lined, beta. Look at screen, everyone. All these cells are interconnected, beta. Look at screen, everyone. This is your middle ear cleft, beta. Okay, please see. This is your mucosa of the nasopharynx. But you know nasopharynx? Same mucosa goes like this. It lines the middle ear. Same mucosa lines the adytus, antrum, and all the cells are mucosa lined. Beta. My dear friends, all the cells, even petrous also, all the cells are mucosa lined. Beta. Every cell is mucosa lined. This system is interconnected. Beta. Let us revise. Beta. There are 5 parts of middle ear cleft. Everybody speak with me. Number 1, Eustachian tube. Number 2, middle ear. Number 3, adytus. Number 4, antrum. And number 5, rest of the ear cells. And we learned today that this all system is interconnected and mucosa lined. When I say interconnected, beta, look at screen, beta. By chance, you got infection in the nose, beta. Okay? Some cold happened, beta. Now the infection reached it from here, from middle ear, it reaches the middle ear, beta. The bacteria went through the Eustachian tube, reached the middle ear, beta. And this stage of disease will be called the otitis media. Otitis media, beta. Otitis media, मतलब middle ear infection. Now, by chance, the infection spread from adytus and all the cells of the mastoid got infected. This stage of disease is called mastoiditis. 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 By chance, infection went from here and reached over here, beta. And that stage of disease will be called petrositis, beta. Petrositis, otitis media, mastoiditis. This is one spectrum of the disease only, beta. Okay? So problem started from the nose to nasopharynx. You just started with a cold, basic cold. And then infection went from the Eustachian tube to middle ear called otitis media. If it goes from middle ear to mastoid, it's called mastoiditis. If it goes from middle ear to petrous apex, it's called petrositis. So this system is interconnected, beta. Okay? Now open up your notes, beta. Open up your notes. Let us do the next topic, beta. Please see spread out disease, beta. I've written the same thing. Nasopharynx to middle ear, otitis media. Nasopharynx to middle ear to mastoid, mastoiditis. And middle ear to petrous apex, petrositis, beta. So this system is interconnected, beta. Am I clear? Chalo. Let us go further, beta. Now next topic is diseases of middle ear cleft. Once you understood that middle ear cleft is interconnected system, let us discuss now various diseases, beta. Now label it. Number 1, beta. Everybody, number 1. ASOM. ASOM, very common problem in my practice. ASOM, acute suppurative otitis media. Acute suppurative otitis media. Look at the name. Acute suppurative otitis media means infection of middle ear. It is infection of middle ear mucosa by pyogenic organism. Suppurative means pyogenic. Okay, it is infection of middle ear mucosa by pyogenic organism. Most common organism to cause this is Streptococcus pyogenes. Streptococcus pyogenes, beta. Most common organism to cause this Streptococcus pyogenes, beta. Infection reaches middle ear from nasopharynx via ET, beta. Very, very simple concept. The problem will always start from nasopharynx. The bacteria will travel via the Eustachian tube. It reaches the middle ear, beta. So problem starts from the common cold. Generally, people have got cold, and then the problem happen in the ear. What is the chief complaint? Earache. Earache, beta. Earache. Okay. Examination shows, draw, beta, red tympanic membrane with dilated capillaries. What is the normal color of tympanic membrane? Everybody. What is the normal color? Pearly grey. This is red tympanic membrane with dilated capillary. Can you see, beta, red tympanic membrane, beta? Red tympanic membrane with dilated capillaries, beta. Now this is called cartwheel sign, beta. This is called cartwheel sign. Cartwheel sign. This is called cartwheel sign, beta. Cartwheel sign. This is called cartwheel sign, beta. Cartwheel sign. This is called cartwheel sign. Okay. Now treatment is medical management. This is no MCQ, beta. This is antibiotic, painkiller, decongestant for cold. You have to give that, beta. Okay. Infection, antibiotic, painkiller for pain, and then decongestant for the cold, beta. But no drug of choice like that. Okay. But the question is this one, beta. Please highlight. This is MCQ. ASOM patient with red. The key word is bulging tympanic membrane. ASOM patient with red, under the word bulging, not red tympanic membrane. Red and bulging tympanic membrane means there is so much of pus filled in the middle ear that if you did not do anything, then nature is going to cause the perforation of the eardrum and the pus is going to come out better. Okay? If you did not do anything, the pus will flow out of the middle ear like this. The red bulging tympanic membrane means the middle is full of pus, and there's so much of pressure on tympanic membrane that if you did not do anything, the pressure of the pus will perforate the tympanic membrane and the pus will flow out like this. This is a problem, it's a complication. You don't want this to happen, do a simple surgery. What? Just do one thing, beta. Do one thing, why not give a cut on the tympanic membrane, beta? Like this. What is the name of this surgery, beta? Maryngotomy. Remember, maring means tympanic membrane, otomy means to give a cut. The treatment is maryngotomy. This is a serious problem. You want to avoid this, you give a clean cut on the tympanic membrane surgically, you put a suction, suck the pus out, this cut will heal within few days automatically. With antibiotic, pus will dry and the cut will heal better. This will save the perforation in this patient better. Otherwise, this will happen better. Okay. Now, look at the screen better. Look at your notes. Treatment is maryngotomy. This is MCQ better. Surgery. Maryngotomy surgery. Maryngotomy surgery. And in which quadrant? Posterior inferior quadrant. Posterior inferior quadrant. MCQ beta. Anybody can tell me, in glue ear, the maryngotomy is done in which quadrant? Anterior inferior beta. Glue ear, anterior inferior. ASOM, posterior inferior. Glue ear, maryngotomy came beta. Glue ear, maryngotomy word came in the glue ear. In glue ear, the maryngotomy is done in anterior inferior quadrant. In ASOM, the maryngotomy is done in posterior inferior quadrant beta. Okay? Now read it beta. If no management is done in a patient of ASOM with red bulging TM, it will lead to perforation of tympanic membrane. Can you see beta? It will lead to perforation of tympanic membrane. Please show over here beta. And the pus will come out beta. Please show the pus has come out beta. Pus. If you do not do this maryngotomy, then the perforation will happen and the pus will come out. It's very common. It's very common, but a lot of people don't reach the ENT doctor. In villages, there are no doctors available, so they don't get the maryngotomy done and the pus will come out. Very common problem. This pus will come out. Now, put an arrow. Still the story is continuing better. Now, if no treatment is taken for next 3 months, further, if no treatment taken for next 3 months after this, it will lead to permanent perforation. Draw better like this. Permanent perforation. Perforation happened. Still you ignored it. In villages, we don't have doctors. ENT doctors are not there. If perforation happened and if no treatment taken is for 3 months, this perforation will become permanent perforation. Means it will never heal on its own now till the time you do surgery. You will have to do surgery for this and it's called permanent perforation. This disease is called SAFE CSOM. This was ASOM, acute. CSOM is chronic. A was acute, C is chronic beta. Why SAFE? It's not a risky disease. Only perforation is there. You can manage it easily. Patient won't die of this problem. SAFE matlab, patient won't die of this problem beta. Okay, bache? Fine. Okay. Now, everyone, this is a permanent perforation beta. It's a permanent perforation. Permanent perforation beta. Permanent perforation. Can you see beta? This is a typical perforation look like beta. Can you see a hole over here? That's a permanent perforation beta. Very common disease. Let us do this now. SAFE CSOM beta. Number 2 disease beta. We have done ASOM. Number 2 is SAFE CSOM. We are doing disease of middle ear cleft beta. ASOM. Perforation happened. You ignored it for next 3 months. The perforation became permanent. And now this stage of disease is called SAFE CSOM. What is C beta? Chronic. SAFE means no risky disease. It won't kill the patient. It is also called tubotympanic CSOM. Tubo means the problem started from the eustachian tube side and it came to the middle ear. Tubo means eustachian tube, tympanic means middle ear. Tubotympanic CSOM is other name of SAFE CSOM. It is characterized by the presence of permanent central perforation in pars tensa of tympanic membrane. It is characterized by the presence of permanent central perforation in pars tensa of tympanic membrane. Three word beta: permanent, central, pars tensa beta. Number one, permanent perforation. Number two, central perforation. And number three, in the pars tensa of tympanic membrane beta. Anybody, what is the lower part of tympanic membrane? Pars tensa. Remember, this is pars flaccida. This is not, there is no perforation in this area beta, okay? Safe CSM should not happen in this area beta. I hope you remember the lower part, the bigger part is pars tensa. So any, this kind of safe perforation, permanent perforation in pars tensa is safe CSM. It is presence of permanent central perforation in pars tensa of tympanic membrane. I do remember pars tensa is the lower part of tympanic membrane beta. Upper part, small part is flaccida. That is not safe CSM beta. Okay, now chief complaint, ear discharge. Why ear discharge beta? Please write down beta. CSOM. What is S? What is S, anybody? What is S? Bolu, what is S? Suppurative. Think logically. Chronic suppurative otitis media. Na? Suppurative means pus. Ear discharge. Discharges not foul smelling, not blood stain. Not foul smelling, not blood stain. Simple pus. Can you see beta? Simple pus coming? Only pus, no smell, no blood beta. Not foul smelling, not blood stained. Okay? Then conductive hearing loss. Yes, middle ear problem na? CHL. Conductive hearing loss. Then ossicle erosion beta. In long-standing cases, there can be ossicular erosion also beta. In long-standing cases, there can be ossicular erosion also. If the patient doesn't take any treatment, there can be ossicular erosion also. Okay? Now please see on the screen beta. Can you see over here beta? Can you see? This is malleus, incus, stapes. This is the ossicle erosion beta. The incus has been eaten away. Malleus, incus, stapes. Gradually full incus will go. After that malleus will also go. Okay? But problems start mostly from incus beta. Now you have a question. Write down. Most common first ossicle to be eroded is incus beta. Why incus? If you remember, incus has no muscle attached to it. So it has least blood supply. MCQ beta. So it has least blood supply. Anybody? Which muscle attaches to malleus? Which muscle attaches to malleus beta? Tensor tympani muscle. Which muscle attaches to stapes? Stapedius muscle. Which muscle attaches to incus? I told you incus has no muscle. And I hope, look at me beta. Look at me, I hope you know every muscle brings some blood supply for the bone. Incus has no muscle. Therefore, incus has least blood supply. Already avascular ossicle. It means easy to damage this one beta. Okay, disease can easily eat away this ossicle. So the story always starts with incus, but very soon, whole incus will be eaten up, whole malleus will be eaten up beta. Then stapes can also be eaten up beta. But if ossicle erosion also happen, that will increase the hearing loss beta. Ossicle erosion will increase the hearing loss beta. Ossicle erosion will increase the conductive hearing loss beta. Incus is the MCQ beta. Both are MCQ beta. Why? Most ossicle to be eroded is incus. Why incus? Because incus has least blood supply beta. Now, treatment is of course surgery, but I told you it's a permanent perforation beta. Think about it. First, look at the first definition. It is presence of permanent perforation in pars tensa beta. You have to do surgery. There is no role of antibiotic, ear drop in this patient. Only thing that you have to make the ear dry before you operate. That's otherwise perforation will never heal on its own. It's a permanent perforation. Surgery is required. The surgical option is maryngoplasty. When you open up the ear from behind and you just put a graft over the perforation. It is the repair of maryngoplasty. Look at the name, maryngoplasty. What is maryng? Tympanic membrane. What is plasty? Repair. Now look at the definition. It is repair of tympanic membrane perforation using a graft. Okay. Most commonly used graft. Everybody note down. Most commonly used graft is temporalis fascia graft. Temporalis fascia graft. Most commonly used graft is temporalis fascia graft. You know, everybody, what is this muscle beta? What is this muscle here? Temporalis muscle beta. This is a graft. From this muscle you take a graft. Most commonly used graft is temporalis fascia graft beta. Okay, bache? Fine. Now, we open up the ear from behind. Okay. And this is the future question beta. This instrument has been asked in NEET PG beta. This instrument has been asked in NEET PG. It can be asked in your exam also, beta. We use a retractor, Mollison self-retaining mastoid retractor, beta. What is the name, beta? Bolo, beta. Mollison self-retaining mastoid retractor to expose the area, beta. We use Mollison's self-retaining mastoid retractor to expose the area, beta. Look at me, beta. When you give a cut, how will you expose the area? You know, in surgery we use retractors. In ENT for ear surgery, what is the name of retractor? Bolo, beta. Mollison self-retaining mastoid retractor. Beta. We put the retractor and we open it, the whole skin goes away from each other, beta, and ear is open over there. So we give a cut behind the pinna and we use this retractor to open up the tissues, beta. Okay, fine. We use which retractor? Mollison self-retaining mastoid retractor, beta. What is the name of surgery? Laryngoplasty. It's a microscopic ear surgery, beta. You do it under microscope because it's a very, tympanic membrane is a very small structure, beta. It's not very big structure, na? So you're operating under microscope, beta. Please see, this is a Mollison self-retaining mastoid retractor. Don't forget this one, beta. Okay, this is Mollison self-retaining mastoid retractor, beta. Okay, fine. Which graft we take? Side of skull, beta. What is this muscle? What is this muscle, beta? Temporalis muscle. Can you see temporalis muscle has got a fascia here? You take a small piece of fascia and you put over there, beta. But this is the before surgery. There's a perforation. Then you put a graft. It's healed completely. Can you see, beta? Before and after, beta. Can you see? Before and after, beta. Can you see? Beautiful results, beta. Before surgery, there is a big central large perforation, which is permanent perforation. You did a laryngoplasty. You put a, can you see white graft over there? And the graft has healed the perforation. Beta. Laryngoplasty. It's repair of tympanic membrane perforation using a graft. Most commonly used graft is temporalis fascia graft. We open the ear from behind and we use a retractor called Mollison's self-retaining mastoid retractor to expose the area. And it's a microscopic ear surgery, beta. Okay. Now there are some other surgery option, beta. Type 3 tympanoplasty, beta. Type 3 tympanoplasty, the second surgery. Now laryngoplasty is very simple surgery. Perforation, graft, khatam. Kuch bhi nahi. But type 3 tympanoplasty is a, this is done. This surgery is done, beta. This surgery is done. Surgery is done when disease has eroded malleus and incus, beta. M minus, I minus, S plus situation. Only stapes left, beta. I told you, disease can eat away the ossicles. First is gone is incus, then malleus also gone, beta, in some cases. In this patient, malleus and incus both are gone. Only stapes is left, beta. Now look at me, beta. Look at me, everyone. Look at me. I hope you remember, look at my hand, beta. Tympanic membrane and ossicle work as one unit. Remember, they move together. Tympanic membrane, malleus, incus, stapes, they work together and they stimulate the cochlea together. But now, situation is different. Beta. What is the situation? Tympanic membrane is here, no malleus, no incus, only stapes is here, beta. No problem, beta. Please understand it, beta. Please understand it, beta. This is malleus, this tympanic membrane. Normally what was happening? Tympanic membrane, malleus, incus, stapes, cochlea. But now, tympanic membrane, there is no malleus, no incus, only stapes. Now, how will the sound energy reach over here, beta, now? Then, please don't forget, you have got a perforation of the tympanic membrane also. You are doing the surgery for perforation, by the way. Now, you put the graft in such a way that it start touching the stapes directly, beta. The graft has to be pushed few millimeters inside. It's not very far away. It's not a kilometer away from each other. It's just, remember, depth of middle ear, 6 millimeter, 2 millimeter, 4 millimeter. That's all. Millimeter. What you do is, look at me, beta. This is stapes. This is tympanic membrane. You put the graft in such a way that it touches the stapes directly. It's only few millimeter away. So that continuity of sound transmission is maintained. Because if you put the graft like this, which graft? Graft to seal the perforation. If you put the graft like this and stapes is here, how will the sound energy go from tympanic membrane to the stapes, beta? There's a difference between the two. So you do one thing, you touch the graft of tympanic membrane with the stapes, beta, so that continuity of sound transmission is maintained. This surgery is called a type 3 tympanoplasty or columella tympanoplasty. Columella tympanoplasty. Look at screen, beta. Look at screen, your notes, beta. This surgery is done when M minus I minus S plus situation. The graft of tympanic membrane is placed in contact with stapes. Okay, this surgery is also called as columellar tympanoplasty. This is the MCQ beta. Columellar tympanoplasty is other name of type 3 tympanoplasty beta. Once again revise with me. What is type 3 tympanoplasty surgery? It is done in which situation? M minus, I minus, S plus situation, means only stape is left. In this case, we do the tympanic membrane surgery. We put a graft of tympanic membrane in such a way that you touch the tympanic membrane graft in contact with the stapes. Why? So that continuity of sound transmission is maintained. This surgery is also called as columellar tympanoplasty. Main surgery is maryngoplasty, which is perforation should be repaired with the graft. Most commonly used graft is temporal fascia graft, and we use a retractor, and the retractor is called Mollison's self-retaining mastoid retractor. Sometimes you do surgery called type 3 tympanoplasty. It is done when there is a malleus minus, incus minus, stapes plus situation. The graft is placed in contact with stapes, and this surgery is called type 3 tympanoplasty or columellar tympanoplasty. Okay, bache? Fine. This was about the second disease beta. Okay. Now, I hope you remember, we are doing a topic of middle ear cleft diseases. We did ASOM, we did safe CSOM, and we just will, after the break, we'll do number 3, mastoiditis beta. Story continues beta. ASOM, perforation happened. 3 months passed, permanent perforation happened. Safe CSOM. I told you, from middle ear, if the infection goes to the mastoid, all the mastoid cell can be infected, and that will be called mastoiditis. I told you, from middle ear, infection can come to mastoid. So we have a lunch break now, but once the lunch break finishes, please come with excitement to learn the next level of disease, when the infection reaches the mastoid cells beta. Okay, so it's a 45-minute lunch break, and we start again at 1:45 beta. 1:45. Okay, it's a lunch break till 1:45, and we start again at that beta. Eat little lesser, take some coffee, tea, wash your face, take some sandwich, some rice, some dal, something like that, but don't eat too much. Get back with a passion to learn mastoiditis, petrositis, unsafe CSOM, how other diseases are actually evolving further. And this is continuity. Okay, fine. Chalo. See you again at 1:45.